Hello everyone, this video is going to be an exploration of cardiac electrophysiology with a focus on anti-arrhythmic drugs. Just to start, I'm an intensive care trainee from Australia. I have no financial conflicts of interest, and this video does not contain any AI bullshit. If you're currently glancing at the runtime and freaking out, I'll clarify this is not one of those short videos where I read you the Vaughan-Williams classification, show you a picture of an action potential for each group, maybe throw in a mnemonic and call it a day. There's a ton of those videos already. There's nothing wrong with them, and I'm sure there are thousands of grateful students who use them. I made this because I can't just memorize the basics without properly understanding. I won't retain it. This is going to be a deep dive. A few years ago, I was helping manage a patient with a tricyclic antidepressant overdose in the ICU. We'd done all the usual stuff. They'd had sodium bicarbonate, they were intubated, we were hyperventilating them successfully, but the wide QRS complex on the ECG was taking a long time to improve. I was on the phone to our toxicology service and they mentioned that if the patient developed serious arrhythmias, we could treat them with lidocaine. The idea of treating a sodium channel blocker overdose with another sodium channel blocker was shocking to me, and I realized that I really didn't understand this family of drugs. Why would that be helpful? How does having a long QT interval lead to torsades? And for that matter, what is torsades, and why are both beta blockers and isoprenolone used in different situations to prevent it when they have exactly opposite effects? I think the best way to know that you've understood something is when you can explain it to someone else. This video took about a year to make in between work and some life events. As fancy as some of the slides are, the vast majority of that time was just spent getting my head around the concepts. If it helps you understand a few of the tricky ones, it might save you a whole lot of time. This video is going to be broken into about 10 sections. There should be timestamps for easy navigation. First, I'll briefly discuss the complexity of this topic and outline the broad types of arrhythmia mechanism. Then I'll introduce into excitable media, functional reentry, spiral waves, and fibrillation. I need to quickly review action potentials and ion channels, particularly sodium channels and conduction. Next, I'll explore the concept of repolarisation reserve and look at some major channelopathies, particularly the long QT syndromes and how they cause arrhythmias. Then I'll examine what calcium does inside of the cell and the other main type of triggered activity. I'll have a brief look at automaticity before discussing the deadliest arrhythmia mechanism, reentry. After that, I'll review the sometimes counterintuitive effects of electrolyte disturbances on the heart. Finally, I'll go through a structured description of the different anti-arrhythmic drug classes and summarize how they should be used in the clinical setting with a focus on wide complex tachycardias. This is one of the most existentially disturbing diagrams I've ever seen. It's a schematic of the alpha subunit of the human fast voltage gated sodium channel 1.5. Note that it has different names specifically referring to the gene, the channel, and the current. To keep things simple, I'll mostly use the current designation, even when referring to channels. Those colored dots represent the sites of known mutations that cause genetic diseases. You might notice that most of the dots are red or green. The red ones represent a loss of function mutation causing Brugada syndrome, and the green ones represent a gain of function mutation causing long QT syndrome type 3. I'll explain why a bit later. The most common presenting symptoms of these disorders are cardiac arrest and syncope. Electrophysiology is a difficult topic because there's a lot of complexity and nuance, and those small details can have a life or death impact on the patient. Despite its relatively simple role, the heart is an incredibly complex organ. It's heterogeneous between atrium and ventricle, left and right, base and apex, endocardium to epicardium. In this video, I'm going to make some generalizations about action potentials, primarily dividing them into slow nodal potentials and the fast potentials in working myocytes. Atrial and ventricular fast myocytes are also pretty distinct, and Purkinje fibers have a third variant of the fast action potential. In one section, I'll also look at the different subtypes across the ventricular wall, but that's about as granular as I'll get. You should remember that in reality, an action potential is unique to every myocyte and might even be heterogeneous within the membrane of that cell. Both the anatomy and physiology of the heart also change over the life of the patient and in different disease states. For example, a myocardial action potential will be different in a patient who has chronic atrial fibrillation or heart failure due to long-term alterations in ion channel function. I'm now going to outline the mechanistic cause of different arrhythmias, and thankfully these are pretty simple. You can have disorders of impulse formation and impulse conduction, and those can generally cause the heart to beat too slow or too fast. There are four broad categories of arrhythmia mechanism. On the impulse formation side, you can have problems with automaticity, where a cell depolarizes on its own, and something called triggered activity, which always follows a previous action potential. On the conduction side, there can be a block in conduction, which tends to cause bradyarrhythmias, and reentrant conduction, which tends to cause tachyarrhythmias. Problems with automaticity can cause brady or tachyarrhythmias. You can have a failure of normal automaticity, leading to not enough impulse generation, or you can have too much impulse generation caused by physiological enhancement of normal automaticity, or abnormal automaticity in partially depolarized cells. Triggered activity happens because of so-called after depolarizations, and these can be early or delayed. Early after depolarizations, or EADs, happen in phase 2 or 3 within the previous action potential, usually at the end of phase 2 because the action potential has been prolonged. Delayed after depolarizations happen in phase 4 after the end of the previous action potential due to intracellular calcium release. On the conduction side, conduction block can be anatomical or functional, and reentry can also be anatomical or functional. In fact, reentry tends to require some form of conduction block, as well as an abnormal impulse to initiate it. The definitive treatment for most significant bradyarrhythmias is pacing rather than drugs, so I'm mostly going to talk about tachyarrhythmias in this video. Many anti-arrhythmic drugs affect automaticity, so I will discuss it, but most purely automatic tachyarrhythmias, for example sinus tachycardia, MAT, and idioventricular rhythm, do not need specific drug therapy, and it can even be harmful in some cases. As a result, the three most clinically important tachyarrhythmia mechanisms are EADs, DADs, and reentry, and those will be the focus of most of this talk. Chapter 1. In this section, I'm going to introduce the concept of an excitable medium, along with the basic prerequisites for functional reentry and spiral waves. These principles underlie conditions such as reentrant polymorphic ventricular tachycardia and fibrillation. The myocardium is an excitable medium, and it's important we have a good understanding of that concept before exploring topics such as reentry. In this context, the term could apply to any 2- or 3-dimensional substrate with two properties. One is that a functional unit can enter an excited state which can propagate to adjacent regions. The second is that the excited state eventually resets so it can be excited again. For example, a room full of mousetraps would easily meet the first property but not the second because they would have to be reset by hand after an arbitrary period of time. One example that has both properties is a forest. A unit of forest can be excited into a state of energy release by a fire, which propagates to adjacent regions like an action potential across a membrane. Immediately after the fire sweeps through, the burnt forest is refractory to being ignited again. But over time it regrows and becomes excitable again. Let's apply this to a simplified model of the myocardium. For our simplified 2D myocardium, imagine this is a normal depolarization wavefront. It can only travel in one direction because, like the bushfire, it has an excited leading edge that is activating resting myocardium ahead of it and a refractory portion behind. In both cases, it's slightly more grey than that because there's going to be smouldering areas within the wave that could trigger excitation, and there'll be partly regrown areas towards the trailing edge that could potentially burn with a large enough stimulus. But we can imagine it for now as a fixed region that can excite the medium on the dotted line ahead and is refractory until the solid line passes. You could calculate this physical wavelength. You just need to remember that distance equals speed multiplied by time. In physics, wavelength equals velocity times the period, which is the inverse of frequency. In our case, wavelength equals the conduction velocity multiplied by the effective refractory period, or ERP. Now, because it's fun, imagine that a forest was so large that in the time it took for a fire to burn all of it, the first part that was burned had time to fully regrow. For that to happen, the wavelength would need to be smaller than the dimensions of the forest. Let's say a bushfire front moves at an average of 5 km per hour and it takes 10 years for a fully burnt forest to regrow to the point that it could be reliably burned again. This works out to a wavelength of over 400,000 kilometers. The Amazon rainforest is about 4,000 kilometers or 100 times smaller. The circumference of the Earth is 40,000 kilometers or 10 times smaller. In fact, you'd need a planet the size of Jupiter, fully covered in forest and solid, obviously, before our permanent fire re-entry circuit was possible. Of course, you could make the fire move more slowly or the plants grow faster, which would reduce the distance needed, but it's safe to say that the average Earth forest is safe from an eternal re-entrant fire. But let's apply this to the human heart instead. Again, this is a simplified visualization. A real wave front would not be 12 cells long. What's a more realistic distance? When relying on myocyte-to-myocyte conduction and without the Purkinje system, a ventricular depolarization typically moves at about half a meter per second. The effective refractory period for a ventricular action potential is variable, but we can use about 300 milliseconds. This gives us a wavelength of 15 centimeters or about 6 inches. The left ventricle is about 6 centimeters across, which gives us a circumference of about 19 centimeters, enough room for a possible re-entry circuit. The remaining 4 centimeters between the start and end of the re-entrant wave is called the excitable gap. There needs to be a gap or a re-entrant arrhythmia will extinguish itself. The reason we usually don't get ventricular tachycardia is that the heart has evolved a sophisticated conduction system. Instead of depolarizing from cell to cell like a paced or ectopic ventricular beat, the ventricle is activated radially outward, almost simultaneously by the Purkinje system. If you set fire to the whole forest at once, the fire will be long gone by the time it regrows, even on Jupiter. This excited leading edge and refractory trailing edge makes single depolarizations inherently safe from causing re-entry. Even a remote focal activation is going to be safe because the excitable leading edge is always isolated from the refractory trailing edge. The radial depolarization will just act like a linear one as it expands. But what happens if you instead created a depolarization right on the trailing edge of the previous wavefront? If you like, you could call it an R on T. The left half of the circular depolarization expands like normal because the medium is excitable, but the right half can't because at that moment it isn't excitable, but it's about to be. As the waves diverge, suddenly we have a raw edge. Is it leading edge or is it trailing edge? Those cells are only halfway through the action potential, so they're not about to reset, and they are depolarized, so they could activate vulnerable tissue. This makes them leading edge. We should never have leading edge meeting trailing edge because that allows for the possibility of a spiral wave. For simplicity, let's just look at one of these intersections. To do that, we can expose half of our main wavefront. This is the easiest way to simulate a spiral wave, by the way. Just disrupt half of your action potential to expose that raw edge, which becomes more leading edge. Let's see what happens next. The main wave keeps propagating forward, but the exposed edge goes laterally and backward. If it's allowed to continue, it will form a continuous spiral. At the core, because the leading and trailing edges meet, there's always excitable medium for it to move into. Like any other wavefront, it does still rely on the wavelength being small enough for re-entry to occur. Imagine you had a drug which had one effect: to prolong the duration of the action potential and by extension increase this spatial wavelength. It might be the most logical way to terminate this arrhythmia. We'll come back to that. Imagine this is taking place in ventricular myocardium. What would it look like on an ECG? You might imagine that because it's continuous ventricular re-entry with relatively slow cell-to-cell conduction, that it would resemble a broad complex monomorphic tachycardia. In reality, these tend to be seen when the re-entry circuit is anchored to an anatomical structure, like an area of scar tissue. This is purely functional re-entry, so it's not anchored to anything and the core can move around. As a result, spiral wave reentry is typically associated with a polymorphic ventricular tachycardia, and that's even assuming that the spiral wave remains intact. Depending on the substrate, there can be either physical or functional heterogeneities that cause the wavefronts to break further. Purely reentrant polymorphic ventricular tachycardia, such as this, can be thought of as on a continuum with ventricular fibrillation. As the wavefronts continue to break up, both the electrical and mechanical activity degenerate into chaos, which is no longer compatible with life. There are several causes of purely reentrant polymorphic VT-VF, most commonly acute ischemia, but there are at least two other forms of polymorphic VT that instead result from triggered activity, one caused by EADs and a more obscure one caused by DADs. These can degenerate into spiral waves and VF, but they don't start out that way. I'll discuss the mechanisms properly in chapters 3 and 4. The reason I put this section at the front and spent so much time discussing mousetraps and bushfires is that I want you to understand that spiral waves and fibrillation are not unique to the heart. They're an emergent phenomena in all kinds of excitable media under the right conditions. I'm sure lots of you will have seen the iodine clock reaction in high school, where the beaker of fluid suddenly goes from clear to black. Well, there's more sophisticated chemical reactions known as chemical oscillators. For example, the BZ reaction shown here. Those can be triggered to change color, reset, and be triggered again. That's an excitable medium, and as you can see, it can generate spiral waves when the wavefront is disrupted, just like the heart. But my favorite example of an excitable medium involves bees. The giant honeybee uses a defensive behavior known as shimmering to confuse predators. In a group like this, they periodically flick their abdomens based on the timing of bees around them, like humans waving in a stadium. This makes giant honeybees an excitable medium. It starts out pretty organized, but later you can see spiral wave formation and even some fibrillation-like patterns. If you see just here, there is a double spiral formation in the middle. Nature's awesome. I could watch this all day. We'll come back to reentry in chapter 6. Chapter 2. Now that I've introduced excitable media, I need to discuss the excitations themselves. I've covered this a few times before, so I'll be quick. 3 sodium ions are actively pumped out and 2 potassium ions are pumped in. The sodium gradient expels calcium via NCX. Both processes are electrogenic, but overall cancel each other out. Remember that positive charge follows the sodium in both cases. There's also active calcium transport on plasma membranes, but it's not nearly as important as for the sarcoplasmic reticulum. These processes generate the various ion concentrations. Their ratios give the equilibrium potential for each ion, and then the relative permeability of the membrane for each ion gives us most of the currents and the membrane potential for a given time. In most cardiac myocytes, diffusion of potassium via the inward rectifier channel IK1 maintains the resting membrane potential, though I'm going to start by talking about cells that mostly lack a resting membrane potential, and those are nodal or pacemaker cells. In phase 4, the permeability of these membranes is determined by the so-called funny cation current. This channel is activated by hyperpolarization and is about 3 times more permeable to potassium than sodium. But since the membrane potential is negative, the driving force for sodium is much higher, and this influx slowly depolarizes the membrane. Eventually, this activates transient T-type calcium channels, accelerating the depolarization. Then the longer-lasting L-type calcium channels are responsible for the phase 0 upstroke. There is no phase 1 or 2 in these cells. Instead, this is followed by activation of the delayed rectifier potassium channels that repolarize the membrane back to phase 4. The refractory period before another phase 0 is possible is determined in these cells by the time L-type calcium channels stay inactivated. This is why the AV node can't conduct as frequently as atrial tissue, for example. When phase 0 is determined by sodium channels, they need the voltage to become sufficiently negative before they can recover from inactivation. The fast action potential in most working myocardium still uses L-type calcium channels and IKR. One difference is that they have a stable phase 4 resting membrane potential due to IK1. They need a stimulus from adjacent myocardium to partially depolarize the membrane to the threshold potential for fast sodium channels, which is around minus 60 millivolts. Once some of those activate, they all activate in a positive feedback mechanism, and the influx of sodium ions rapidly depolarizes the membrane towards the positive sodium equilibrium potential. The sodium channels inactivate after 1 to 2 milliseconds in a time-dependent fashion. In phase 1, the transient outward potassium current pulls the membrane back towards zero. This makes the subsequent plateau phase more efficient because the electrochemical force for calcium influx is greater. In phase 2, there is relatively little ion movement in either direction, but a dominant current is via the L-type calcium channels, which activate significantly slower than the sodium channels. Calcium channels inactivate via two important mechanisms: voltage-dependent and calcium-dependent inactivation. Calcium-dependent inactivation provides an internal negative feedback mechanism, as most of the calcium released into the cytosol comes from the sarcoplasmic reticulum, and additional external calcium is not required. As L-type calcium channels start to close, the balance of current shifts from depolarization to repolarization, thanks to the effect of delayed rectifier potassium currents. The most important, known as IKR with R standing for rapid, is unique because it tries to open in phase 0 but is temporarily inactivated by its selectivity gate before it conducts any current. Then it progressively opens as the membrane starts to repolarize in phase 3 and becomes the dominant mechanism, pushing the membrane back to its resting potential. The IKS, with S standing for slow, channel has a sub-maximal contribution to repolarization at rest, a fraction open with each action potential, and contribute to repolarization in subsequent action potentials, shortening the action potential as heart rate increases. This current is greatly enhanced by sympathetic stimulation, and it becomes the dominant repolarizing force during sustained exercise. The atria also have the ultra-rapid delayed rectifier channel, which is responsible for the action potential being shorter in atrial tissue. When the membrane becomes sufficiently negative, sodium channels finally recover from inactivation and return to their closed state, waiting for the next stimulus. This marks the end of the refractory period. So far, I've only talked about the action potential at a single point in the membrane. How does the signal propagate? It all happens in phase 0. When the membrane depolarizes, it triggers sodium influx, which depolarizes the adjacent membrane and triggers those sodium channels to open. This continues just like a line of dominoes falling. All that matters is phase 0. This might be easier to think of in the bushfire analogy. If you ignore effects like wind, the speed at which a fire propagates only depends on the time it takes for each piece of fuel to catch fire. It doesn't matter how long each part burns for, and certainly not how long it takes to regrow afterwards. The greater the sodium conductance, the faster the signal can propagate, and vice versa. But remember, both types of action potential have a phase 0. In nodal tissue, most importantly the atrioventricular node, phase 0 is primarily determined by L-type calcium channels, which take about an order of magnitude longer than sodium channels to open. This difference is amplified by the positive feedback of depolarization, meaning that the phase 0 slope is much less steep than for sodium-driven action potentials. And that slope is the primary determinant of conduction velocity. These concepts are critically important for anti-arrhythmic drugs. Calcium channel blockers will profoundly decrease AV nodal conduction. Beta blockers are effectively indirect calcium channel blockers, so they do as well. Sodium channel blockers depress conduction velocity in working myocardium and Purkinje fibers where the phase 0 is fast sodium channel dependent. Sodium channel function can also be impaired under conditions such as hyperkalemia. To see how, let's look back at the phase 0 membrane in a little more detail. Sodium channels effectively have three states: closed, open, and inactivated. When the membrane depolarizes, closed channels open, then rapidly inactivate. They stay inactivated until the membrane repolarizes. The membrane repolarizes and stays polarized due to potassium efflux, approaching its equilibrium potential. In hyperkalemia, there is less of a concentration gradient, so the equilibrium potential for potassium is more positive. Therefore, some sodium channels never recover to the closed state. The membrane isn't negative enough. These inactivated sodium channels are unable to contribute to the next depolarization, and there is a progressive attenuation of conduction velocity. This is an example of a classic ECG findings in hyperkalemia. This patient had a potassium of 7.6 due to end-stage renal failure. The QRS complex represents ventricular depolarization, and specifically it depends on rapid conduction through the His-Purkinje system. Sodium channel inactivation reduces the slope of phase 0, and the cumulative effect of all of those phase 0 dominoes, each falling very slightly slower, results in a very visible prolongation of the QRS duration from about 80 milliseconds normally to about 200 milliseconds in this case. Other distinctive features include very tall pointed T waves, best seen in V3 and V4 in the inferior leads, as well as downsloping ST elevation in AVR and V1. Here's another ECG with a similar pattern, broad QRS complex, downsloping ST elevation in AVR, V1 and V2, except this is from a patient with a TCA overdose. Tricyclic antidepressants are cardiac sodium channel blockers. Specifically, they act like class 1A antiarrhythmics. First-line therapy in this case is sodium bicarbonate and hyperventilation. Give calcium as well if it might be hyperkalemia. At the start I mentioned that lidocaine is sometimes used in TCA overdose. This is not first line and relates to particular nuances between the different subclasses. You never want to give a sodium channel blocker in hyperkalemia. That is an important pitfall for broad complex rhythms. Keep looking at V1 and V2. This is a very similar ECG, except this time with a narrower QRS complex. This is from a patient with classic ECG findings of Brugada syndrome, which most typically results from a loss-of-function mutation in the fast sodium channel gene. I will discuss two theories as to how this ECG pattern is formed in Chapter 6. Actual myocardium is a little more complicated than a continuous membrane, but the principle is the same. On the surface, the wavefront is propagated by phase 0 sodium influx, but between myocytes, ions need to diffuse through gap junctions channels known as connexins. Myocardium is not homogeneous in all directions. The physical layout and connections of the cells create a sort of grain, which means that impulses conduct anisotropically, with different velocities in different directions. This means that on a macroscopic level, sodium channels are not the only factor. Here's another broad complex ECG, this time from a patient with bupropion toxicity. Bupropion is a novel antidepressant that can be horrifically toxic in overdose, causing seizures, coma, and cardiovascular collapse. Bupropion does not block sodium channels, it blocks gap junctions, the connections between the cells. How do you reverse the cardiovascular collapse? Essentially, you can't. You can try treatments like sodium bicarbonate, but you may have to stick them on VA ECMO until they metabolize to freedom. That's how myocytes are electrically coupled across these intercalated discs, but how are they mechanically coupled? The heart beats with a lot of force. These complexes are called desmosomes, and essentially they hold the heart muscle together. Why am I mentioning them? Because there's a disease called arrhythmogenic right ventricular cardiomyopathy or dysplasia, which is due to genetic defects in these structures. It tends to manifest between the ages of 10 and 50. Cellular connections slowly tear apart and the muscle is replaced with fatty fibrous tissue. The earliest affected regions include the right ventricular inflow and outflow tracts, as well as the posterolateral left ventricle. The first symptoms are usually life-threatening ventricular arrhythmias, followed eventually by progressive cardiac failure. ARVC often has distinctive manifestations on ECG. These can include T-wave inversion in anterior leads, terminal activation delay with a prolonged S-wave upstroke, and the presence of an epsilon wave following the S-wave. Here's another example that happens to include a run of monomorphic VT. Chapter 3. We've talked about depolarization, now let's talk about what can go wrong with repolarization. This section is about early after depolarizations and the long QT syndromes. Bear with me for a second. In the final episode of the brilliant HBO miniseries Chernobyl, the protagonist, Valery Legasov, needs to explain to a hearing and the audience the complex chain of events that led to the reactor exploding. The show achieves this with the use of simple props, a set of red and blue cards. Red represents factors that increase the energy of the nuclear reaction, and blue factors that decrease it. By adding and removing them while retelling events, it demonstrates how the workers completely destabilize the reactor, initially by over-dampening the reaction and then catastrophically in the other direction. It's a great scene and it inspired me here. I'm going to apply the same principle to the cell membrane for factors that depolarize the membrane and factors that repolarize it. For example, the ATPase moves the charge of 1 out, so that is a repolarizing factor and gets a purple card, purple for potassium. The NCX in its forward direction moves 1 charge in, so it's a depolarizing force and gets a magenta card, which I'll call pink for sodium. Charges follow sodium for both and they cancel each other out, so overall have no effect on the membrane potential. IK1 is what establishes the resting membrane potential, polarizing the cell in phase 4 through potassium efflux. The difference between cardiac myocytes and a nuclear reactor in this exercise is that the membrane potential needs to oscillate between two distinct voltages in a controlled fashion. In phase 0, we have a stimulus that immediately opens the fast sodium channels, depolarizing the membrane. IK1 has something called inward rectification, so it functionally closes when the membrane is depolarized to allow for the plateau phase. With the change in voltage and sodium influx, the driving force for NCX reverses and it starts carrying calcium in and sodium and charge out, making it a repolarizing current. After 1 or 2 milliseconds, the sodium channels inactivate, so there's no longer any factors working to depolarize the cell membrane. The next channels to open are the transient outward potassium channels that define phase 1. They push the membrane potential closer to neutral and rapidly inactivate, while the L-type calcium channels are opening at the start of phase 2. Notice that despite the calcium, the potential is still becoming more negative because other potassium channels are opening. In the atria, there's the ultra-rapid delayed rectifier that's responsible for the short atrial action potential, while in the ventricles there's just the rapid and slow delayed rectifier potassium channels. Notice how many purple repolarization cards there are at this point. This is known as repolarization reserve. It's critically important that the membrane returns to its depolarized state in phase 3, so there's a degree of redundancy. Before we get to phase 3, I should also briefly mention that there is one more depolarizing current, known as the late sodium current. This is carried through a tiny fraction, about 1%, of the fast sodium channels from phase 0 that remain open. Because it's over such a long time, the total current can be significant, particularly in pathological states. As the membrane starts to repolarize in phase 3, NCX flips back into forward mode, trying to counter that change. The L-type calcium channels are inactivated and IK1 reactivates, ensuring a safe return to the resting membrane potential. Delayed potassium channels, particularly IKS, take a very long time to close and can potentially have a cumulative repolarizing effect on subsequent action potentials, for example during tachycardia. So what happens if we start messing with these cards? Rare genetic lesions known as channelopathies can show us the result of altering function of these ion channels in a more precise fashion than drugs or toxins. I'm only looking at 5 major currents and typically the alpha subunit. Like before, the fast sodium and L-type calcium channel are depolarizing forces, and almost all potassium currents are repolarizing forces. We've already heard that a loss-of-function mutation of the fast sodium channel is the major cause of Brugada syndrome. This can slow conduction, but it also makes the plateau more negative, particularly when the transient outward current is prominent. Gain-of-function mutations in that channel also have minor associations with Brugada syndrome, as do loss-of-function mutations in the L-type calcium channel, although these are also associated with a short QT syndrome. If you decrease a depolarizing current or increase a repolarizing current, it will shorten the action potential as you have increased repolarization reserve. The two main short QT syndromes are caused by gain-of-function mutations in the rapid and slow delayed rectifier channels. The short QT3 syndrome is caused by a gain-of-function of IK1. Predictably, the opposite is also true. The two main types of long QT syndrome are caused by loss of function mutations in the slow and rapid delayed rectifier channels, causing a loss of repolarization reserve. The KV7.1 channel for IKS is also sometimes known as KV long QT1. Interestingly, long QT type 3 is caused by a gain of function in the fast sodium channel, such that the late sodium current is more prominent. Gain of function in the calcium channel causes a multi-system disorder known as Timothy syndrome, which includes QT prolongation, and loss of function of IK1 causes Anderson-Tawil syndrome, which also involves QT prolongation. The reason I'm starting by talking about genetic disorders instead of drugs is that it's conceptually easier, as almost all antiarrhythmic drugs have multiple effects. We can make some predictions though. In the last chapter, you saw that the tricyclic antidepressant overdose can resemble Brugada syndrome on an ECG because both involve sodium channel blockade. TCAs are most similar to class 1A antiarrhythmic drugs. Another class 1A agent, argmaline, as well as class 1C agents like flecainide, have been used to unmask Brugada ECG patterns in at-risk patients without the full phenotype. On the other hand, quinidine, despite being a 1A agent, also causes significant blockade of the transient outward current and has therefore been actually used to treat Brugada patients. The most notorious drug-gene interactions are with the IKR or 11.1 potassium channel, also known as HERG, due to a biologist in-joke about fruit flies. This is the site of action of most class 3 antiarrhythmics and most cases of drug-induced QT prolongation. But what is the problem with QT prolongation anyway? QT prolongation represents a progressive failure of repolarization reserve. As I mentioned with the cards, the myocyte membrane needs to oscillate between two distinct states, depolarized and repolarized. We're going to be looking specifically at phases 2 and 3. The heart needs a plateau phase to allow calcium signaling to trigger contraction. The prolonged action potential duration also prevents reentry, but the plateau can't last indefinitely. It needs to repolarize after a precise time. Repolarization reserve makes sure that happens. If we start chipping away at this reserve, it will start to prolong the action potential and therefore the QT interval. This will take multiple hits, which could include genetic mutations, drugs, hypokalemia, or autonomic signaling, but eventually it hits a danger point of time and voltage where calcium channels can reactivate and start depolarizing oscillations around a third stable voltage. This is known as an early after depolarization, which typically occurs at the end of phase 2. With more hits, there could be multiple consecutive EADs. The membrane is still too positive for sodium channels to be available, but the calcium channel mediated oscillations can start to resemble slow pacemaker action potentials. With enough hits, the membrane fails to repolarize completely. If this happened to the whole myocardium, computer models suggest that it could remain an excitable medium, but just for these slow calcium waves. Unfortunately, the heart also needs to relax, so this would cause systolic arrest with no useful mechanical activity. In the more likely case that only some cells fail to repolarize, there would be a sustained source for triggered activity. Who's most at risk for EADs and repolarization failure? Patients with congenital long QT syndromes who've already had a hit to their repolarization reserve. The vast majority of these patients fall into types 1 to 3. Long QT1 accounts for about 50% and is caused by a loss of function mutation in IKS. It tends to manifest with ventricular arrhythmias during sustained sympathetic stimulation such as exercise, especially swimming. Long QT2 involves a loss of function of IKR, also known as HERG. It's a bit less common, affecting about 35 to 40% of patients. Episodes are classically triggered by sudden auditory or emotional stimuli, such as an alarm clock. Long QT3 is caused by a gain of function in the fast sodium channel and accounts for about 8% of patients. It most commonly causes arrhythmias during sleep. I'll discuss the reasons for different phenotypes between types 1 and 2 in Chapter 8, along with acquired QT prolongation. For now, we can just focus on a failure of repolarization reserve. The baseline ECGs all have slightly different morphology, but all show a prolonged QT interval. The QTC correlates to some extent with repolarization failure and arrhythmia risk. You should be particularly worried if you see a QTC more than 500 milliseconds, or if the QT interval takes up 50% or more of the RR interval. There are also more concerning features. There's two distinct rhythms here, but for now I want you to focus on this section. You should be able to see that it's currently sinus. It's regular with P waves, but there's something weird about the T waves and the QT interval. Every second beat has a giant T wave, and the QT intervals are markedly prolonged, reaching all the way to the next P wave. This is QT T wave alternans, and the abnormal T waves are a visual indicator of ventricular early after depolarizations. The QT is markedly prolonged because the action potentials are markedly prolonged due to EADs. Those EADs haven't triggered any extra beats, but that's about to change. Watch the RR intervals because it's going to be a recurring pattern. We get an extra beat here that shortens the RR interval and prolongs the next interval due to a compensatory pause. That pause exacerbates EADs on the next beat, leading to another ectopic right at the end of the previous QT interval. This is an EAD-triggered beat. I suspect that the original ventricular ectopic was as well, but it could be anything. The pause is the important part. You can see this pattern repeating. We've now gone from sinus rhythm to an EAD-triggered ventricular bigeminy. This rhythm is a medical emergency because it's the last warning sign for repolarization failure. You probably know what the next rhythm is going to be. This is torsade de pointe, which I will generally refer to as torsades. In this case, it is non-sustained. The trace shows the same short-long-short pattern with an EAD triggered beat after the final short, known as the coupling interval. This tends to be on the longer side for torsades compared to other causes of polymorphic VT. This is another example that's sustained and appears to be associated with loss of output. You can see that it doesn't have the initial short this time, just the pause and then the abnormal QT segment leading into an EAD triggered beat. The thing that took me a very long time to understand is what exactly is this polymorphic VT? Is it like the spiral wave animation? Does a trailing edge EAD start a purely reentrant arrhythmia? That doesn't fit with a loss of episodes of torsades being transient. EADs tend to be self-limited because faster heart rates shorten the action potential. But it's not one single focus of depolarization failure either, because that wouldn't explain the classic twisting morphology. The answer seems to lie in non-human experimental models. This European group used dogs with chronic atrioventricular block that were known to be at high risk of torsades. They placed a 3D array of needle electrodes in the myocardium so they could track electrical activity at various points simultaneously while the arrhythmia was happening in order to distinguish focal activity from reentry. This one does resemble a spiral, for example. Then they fed those patterns into algorithms that used the geometry to detect whether reentry was present at a given time and record all the different arrhythmias with those findings. What they found was a fascinating spectrum of pathophysiology. For short runs of torsades, the arrhythmia was purely focal with no reentry. All of these beats are EAD triggered. With longer runs, there was a pattern of focal EAD triggered activity, then reentry, then focal. Finally, for sustained runs of torsades, it was focal and then continuous reentry. These rhythms would be responsible for sudden cardiac death. You can see a breakdown of all episodes here. I got a little bit obsessed with torsades because I knew what reentrant polymorphic VT looked like. It's the spiral waves and things that we saw before, but what do polymorphic EADs look like? These awesome scientists wanted to know too, so they used a combination of computer and animal models to show us. Starting with the 2D computer model, there are the normal linear wavefronts from chapter 1, except on the trailing edge there are additional depolarizations which represent EADs. These lead to secondary wavefronts looking like reflections. There's a bit of clustering that causes just enough heterogeneity for reentry to start. They also applied this to a 3D ventricular model and then compared that model with experimental data from rabbit hearts that have been exposed to oxidative stress, which can also trigger EADs, as you see there. These are the best cellular visualizations I could find for torsades. They're very beautiful. I suggest you check out their paper online for the full videos. Delayed after depolarizations are the other important cause of triggered arrhythmias. They are seen with catecholamine stimulation, digoxin toxicity, and a channelopathy known as CPVT. Before we get to those, we should look a little bit closer at the roles of calcium within the cell. A lot of cardiac muscle structure and function is very similar to skeletal muscle. You have myofibrils and sarcomeres, and sarcoplasmic reticulum linked to T-tubules. This particularly applies to ventricular myocytes. Nodal cells and a significant fraction of atrial myocytes have sarcoplasmic reticulum but lack T-tubules. For these atrial myocytes, membrane depolarization only triggers calcium release from superficial sarcoplasmic reticulum, but the signal can reach deeper when augmented by beta-adrenergic stimulation. In cardiac muscle, membrane depolarization comes from automaticity and cell-cell conduction rather than neuromuscular stimulation, but the propagation of signals is similar. The molecular mechanisms in the triad are similar but not identical to skeletal muscle. Cardiac muscle uses L-type calcium channels CAV 1.2 rather than 1.1 and the ryanodine receptor 2 instead of RYR1 in skeletal muscle. Their coupling is also slightly different. Sodium channels depolarize the membrane and open calcium channels, but it takes actual calcium influx and direct stimulation of the ryanodine receptor to trigger calcium release, unlike skeletal muscle where there's a mechanical linkage between the calcium channel and ryanodine receptor. Confusingly, cardiac muscle uses troponin C type 1 instead of type 2 in skeletal muscle. Cardiac troponin C has one non-functional calcium binding site and two are occupied with metal ions at baseline, so only requires one additional calcium to trigger a conformational change and expose myosin binding sites. Then myosin heads are able to attach with ADP and phosphate. Phosphate dissociates, triggering a power stroke and mechanical work. ADP is exchanged for new ATP, triggering dissociation from the filament. Then ATP is hydrolyzed and the myosin head undergoes another conformational change. This sliding filament contraction continues as long as the calcium remains bound to troponin C. Once the action potential ends, circuit activity returns calcium to the sarcoplasmic reticulum. Calcium leaves the troponin complexes, covering up the myosin binding sites, and this leads to relaxation of the filaments. One thing I haven't covered previously is that about 1% of the calcium flux enters the mitochondria. Calcium regulates the force of contraction, but contraction requires energy in the form of ATP. ATP synthase is powered by a proton gradient across the inner mitochondrial membrane, and that gradient is established by a series of interlocking redox reactions, which are powered by molecular oxygen. The mitochondrial matrix calcium concentration is kept low at baseline by sodium-calcium exchanges, powered by the same hydrogen gradient as ATP synthase. Parts of the outer mitochondrial membrane are coupled directly to the sarcoplasmic reticulum, so during excitation-contraction coupling, calcium is channeled into the intermembrane space. That high concentration opens the mitochondrial calcium uniporter, which functions like a one-way valve, letting calcium into the matrix. Once inside, calcium binds to and upregulates pyruvate dehydrogenase and two key enzymes in the citric acid cycle, acting like an accelerator pedal for the whole process. This burst of respiration takes place with each heartbeat. When the outside concentration falls, calcium is shuttled back out by NCX. It's now time to look even closer at the process of calcium release from the sarcoplasmic reticulum. The mechanism for delayed after depolarizations, or DADs, is entirely different from EADs. I designed this hydraulic analogy to better illustrate how and why they occur. The height of yellow liquid in various regions represents calcium concentration. On the right, you can see it's actively pumped out of the cytosol into the sarcoplasmic reticulum by SERCA, and into the extracellular T-tubule on the left by NCX in exchange for sodium. The sodium is then pumped out by the ATPase in exchange for potassium. Both are electrogenic but cancel each other out. On the far left, we have a yellow sluice gate, which is the L-type calcium channel, and towards the center is the large orange gate representing the ryanodine receptor. The ryanodine gate is usually opened by a sensor shown below it that detects cytosolic calcium. Importantly, the ryanodine gate is affected by the level of calcium both in the SR and in the cytosol. Following membrane depolarization, the L-type calcium channel opens and a small amount of calcium trips the sensor under the ryanodine receptor, opening the gate. Because the SR calcium is much higher than in the cytosol, there's a large efflux of calcium. The cytosolic level rises and the SR level falls. This continues until forces from either side effectively equalize and the ryanodine receptor closes. CICM and NCX then return the calcium levels to baseline. Now imagine that the SR is depleted of calcium for some reason. Now if the membrane depolarizes, even if the calcium sensor is tripped, the ryanodine receptor doesn't open. It needs that pressure from the SR. Let's look at some situations that increase the sarcoplasmic reticulum level. If someone takes digoxin, it inhibits the sodium-potassium ATPase. Normally this keeps intracellular sodium levels low, which provides a sodium gradient for NCX. By inhibiting the ATPase, digoxin raises intracellular sodium and prevents NCX from expelling calcium. This is how it works as a positive inotrope. What about other inotropes? Beta agonists stimulate adenylyl cyclase, CAMP, and PKA. PKA upregulates the L-type calcium channel, leading to more calcium influx. Beta blockers inhibit this pathway, as do adenosine and phosphodiesterase. Methylxanthines like caffeine and theophylline inhibit adenosine and phosphodiesterase and are therefore proarrhythmic. Milrinone also inhibits cardiac phosphodiesterase. As a general rule, all positive inotropes are proarrhythmic. PKA has a lot of effects though. For example, it actually has the opposite effect to digoxin on the ATPase. CAMP increases the heart rate through its effect on the funny channel, and a greater heart rate leads to more intracellular sodium, inhibiting NCX. PKA also stimulates the ryanodine receptor and indirectly stimulates CICM, allowing faster relaxation, but also meaning that the SR is better at hoarding calcium. So what happens when the SR calcium level rises too high? This can be due to digoxin, tachycardia, endogenous sympathetic stimulation, and anything that enhances that pathway, potentially also extracellular hypercalcemia. Well, eventually the pressure just pushes open that gate and you get a spontaneous release of calcium. This is most likely to happen a little while after the action potential, once the cytosolic calcium has returned to the SR. What if the ryanodine gate is faulty and sometimes just breaks open under normal pressure? There's one more genetic channelopathy I haven't discussed so far because it's not in a membrane ion channel, it's actually the ryanodine receptor. Gain of function for RYR1 in skeletal muscle causes malignant hypothermia, while gain of function for RYR2 in cardiac muscle causes catecholaminergic polymorphic ventricular tachycardia. But what's the problem with the spontaneous intracellular calcium release? How does that even affect the membrane potential? Look back at the NCX transporter on the left. More calcium in the cytosol means more calcium efflux via NCX. 1 calcium out for 3 sodium in makes membrane potential less negative, and that phase 4 depolarization is a DAD. If the DAD is large enough, it can activate sodium channels and lead to a whole new action potential, which is known as a triggered beat. Sometimes that calcium efflux is enough to terminate further beats, but DADs are enhanced by tachycardia and can potentiate themselves under the right conditions. For clarity, I haven't shown the calmodulin-associated kinase signaling pathway, but you can just think of it as an amplifying factor for everything stimulated by the CAMP and PKA pathways, and it certainly contributes to DADs. I'm now going to show you a proposed mechanism for the archetypal DAD-mediated arrhythmia, bidirectional ventricular tachycardia. This rhythm is rare. It's almost exclusively seen in digoxin toxicity and catecholaminergic polymorphic VT. I've seen it once in a patient with digoxin toxicity. Like with torsades, there can be a spectrum of findings as the triggered activity ramps up, and the arrhythmias may be non-sustained or sustained. Unlike torsades, DAD-triggered activity is worse with rapid heart rates, though both are exacerbated by sympathetic stimulation. The theory focuses on the His-Purkinje system. Imagine we have a patient with catecholaminergic polymorphic VT who is currently in a nice, slow sinus rhythm and is about to undergo an exercise stress test. On the right, we have two action potentials from subendocardial myocytes at the Purkinje myocardial junction. The upper one is near the posterior fascicle and the lower one is near the anterior fascicle. If you look closely, both action potentials already have subthreshold DADs. Triggered activity is heart rate dependent, and the threshold is probably going to be different at different sites. So let's just say arbitrarily that if the cells near the posterior fascicle are stimulated at over 65 beats per minute, it will result in a single DAD triggered beat after each complex. The anterior one is less sensitive, so that will only trigger at a beat faster than 100 beats per minute. Let's see what happens when the heart rate increases. The next beat corresponds with a heart rate of 67, meeting the threshold for a posterior fascicle triggered action potential. This undergoes retrograde propagation through the His-Purkinje system and might, in isolation, lead to a ventricular bigeminy pattern. But this extra action potential also reached the anterior fascicle, and the time between its last two action potentials now would correspond with a heart rate of 104. That means we've met the threshold for an anterior fascicle triggered beat. The heart rate's definitely more than 65 now, so we have another posterior fascicle beat. This continues in a ping-pong fashion, creating bidirectional ventricular tachycardia. It's not reentry, it's purely DAD triggered activity. You can think of it as bigeminy bouncing between two branches of the conducting system. This can look very strange on an ECG if you're not familiar with it. The most important thing is probably to look at multiple leads. If you looked at some of the limb leads, especially AVR, you might mistakenly think this is a weird broad complex morphology at 70 beats per minute instead of two alternating broad complex morphologies at 140 beats per minute. Here's another example, this time in a CPVT patient. But why is it called catecholaminergic polymorphic VT? This is only dimorphic. Well, what if there are other foci that start triggering at even faster rates? For example, the right bundle. This could alternate with the posterior fascicle, or the septal fascicle. You can get quite chaotic patterns. I'll just let it play out for a bit. Now we have a polymorphic ventricular tachycardia. It does actually look like that. Here's a rare 12 lead from the Wikipedia page. Notice that it looks nothing like torsades. And this is an example tracing from an exercise test showing the ramp up of more bizarre rhythms and then resolution as the sympathetic stimulation settles down. Like torsades, it can sometimes degenerate into a reentrant polymorphic ventricular tachycardia, namely VF. We've almost finished with triggered activity, but there's one more DAD-mediated arrhythmia to mention. We've just seen how DADs can cause a polymorphic VT through this ping-pong mechanism, but what if there's only one focus with runs of sustained oscillations instead? This is a monomorphic VT originating in the RV outflow tract. It's a common cause of VT among patients without structural heart disease, and it's one of the few ventricular arrhythmias that responds to adenosine through inhibition of the CAMP pathway that's stimulating the DADs. It's also known as repetitive monomorphic VT because it often has short runs that self-resolve. It's considered more benign than other forms of VT, though it does need to be distinguished from other potential diagnoses, such as arrhythmogenic cardiomyopathy. Chapter 5, Automaticity. This section is going to be pretty short because, as I mentioned, most automatic rhythms don't need to be treated with drugs. That said, a lot of anti-arrhythmic drugs do affect automaticity, and it's helpful to know the underlying mechanisms. The heart needs automaticity to function, so there is a hierarchy of redundant pacemakers throughout the heart, with decreasing intrinsic rates. I've put some typical values here. Obviously, there will be variability between patients and clinical situations. If we plot those rates on this ladder diagram, we can see that under usual circumstances, the sinus node captures all of the other sites because its intrinsic rate is the fastest. So what regulates the sinus rate? In 1982, researchers gave titrated doses of atropine and propranolol to volunteers to assess the effect of basal autonomic tone on heart rate. In one group, they started with muscarinic blockade, followed by adrenergic blockade. In the other one, they blocked adrenergic first, and then muscarinic. There's a nice symmetry to it, and it didn't have a lot of hysteresis. To summarize the envelope they traced out, we can see that without any autonomic modulation, the intrinsic sinus rate in these subjects was about 100, and that at rest, the parasympathetic tone seemed to have a greater effect. We could also relabel the diagram in physiologic terms rather than pharmacological. It's worth noting that the magnitudes of these effects are just for resting tone. For example, intense parasympathetic stimulation can push the heart rate much lower, potentially to 0. Likewise, intense sympathetic stimulation can push the heart rate much higher. A rule of thumb I'll call back to later is that the maximum possible sinus tachycardia rate for a patient is approximately 220 minus their age. For most adults, this works out to about 150 to 200. What is the mechanism of this normal automaticity? To understand this, we need to look back at the slow action potential which controls the intrinsic rate of the SA and AV nodes. The key events are phase 4 slow depolarization, which is determined by the funny cation channel IF, and to a smaller extent the faster phase 0 depolarization, which is mostly determined by the L-type calcium channel. There is another theory I'll just mention in passing known as the calcium clock hypothesis, which suggests that calcium cycling within the cell generates automaticity in parallel with the funny current on the membrane. It's certainly possible that it contributes, but the facts that large doses of ivabradine, which inhibit the funny channel, and mutations in the gene for the funny channel both cause severe bradyarrhythmias would suggest that phase 4 membrane depolarization is necessary and sufficient for normal automaticity. So together, phase 4 and phase 0 determine the RR interval, which give us a rate. In this example, imagine that it's a sinus node with a basal discharge rate of 75 per minute. With sympathetic stimulation, autonomic nerves release noradrenaline, which activate beta-adrenergic receptors and the G-alpha-S pathway, with adenylyl cyclase increasing CAMP. CAMP increases the conductance of the funny channel. That's why the channel's gene name has cyclic nucleotide gated in it. This increases the slope of phase 4 depolarization and shortens the RR interval. CAMP also stimulates protein kinase A, which upregulates L-type calcium channel conductance, further shortening the RR interval but not as dramatically. Meanwhile, acetylcholine released from parasympathetic nerves stimulate the M2 muscarinic receptor bound to the G-alpha-IO pathway, which inhibits the effect of CAMP, reducing both of the previous effects. The beta-gamma subunits also stimulate the KACH or GERK potassium channel, relatively hyperpolarizing the membrane and giving phase 4 depolarization a longer way to go, significantly extending phase 4 and the RR interval. As you can see here, adenosine causes the same effects through its own inhibitory G protein receptors, which explains why exogenous administration of adenosine leads to a sinus pause. The other cause for a hyperpolarized phase 4 is overdrive suppression, where sodium accumulates at very fast heart rates, and then its expulsion through NCX and the ATPase are electrogenic because charge follows sodium, and as described in the EADs section. This can be a reason for a brief pause after the resolution of a tachycardia. Various antiarrhythmic drugs affect this process at different points. I'll just show the sites here if you're curious, but I'll discuss them in much more detail in Chapter 8. That's an overview of normal automaticity. Enhancement of these physiological processes can cause tachyarrhythmias, such as sinus or certain ectopic tachycardias. The other possible cause for automatic tachyarrhythmias is abnormal automaticity. For this, we need to look closer at potassium conductance. In non-nodal cardiac myocytes, the resting membrane potential is primarily determined by the IK1 channel. The sodium-potassium ATPase has established a large potassium concentration gradient, which gives a theoretical equilibrium potential around minus 94 millivolts. This means that if potassium was the only factor, at a membrane potential of minus 70, potassium would still want to leave, which would push the membrane potential towards its equilibrium potential, and likewise for more hyperpolarized values. The graph just shows the direction and magnitude of the potassium current based on the current membrane voltage, and this current travels through the IK1 channel. But there's a problem here. If the membrane was to fully depolarize, the electrochemical force and resulting potassium current would be massive. IK1 wouldn't allow the broad phase 2 plateau. It would repolarize the action potential immediately. To prevent this, IK1 has a property called inward rectification. As the membrane depolarizes, internal ions such as magnesium block the pore and prevent potassium from escaping. Inward rectification means that this anchoring effect of IK1 only becomes prominent when the membrane is relatively close to minus 94 millivolts, i.e. in phase 4 and late in phase 3. That is why delayed rectifiers such as IKR and IKS are so important for repolarization. They need to get the membrane down to a range where IK1 can take over. But what if for a pathological reason such as ischemia or digoxin toxicity, the resting membrane potential became more positive? IK1 would start to be blunted by inward rectification. So what takes over? Most cardiac myocytes do have a few funny channels in their membranes, but their contribution is swamped out by the much larger number of IK1 channels. The equilibrium potential for all ions doesn't depend on the absolute conductance for each ion, just the relative conductance. So when IK1's pure potassium conductance is less prominent, the funny channel's potassium and sodium conductance will start pushing the membrane towards around minus 30, which is easily enough to activate voltage-gated channels. What does this mean? If the membrane is pathologically depolarized, instead of having a fixed, very negative phase 4, we have gradual depolarization in phase 4, also known as abnormal automaticity. For the extreme case, think about what also gets inactivated when the membrane is gradually depolarized: fast sodium channels, like in hyperkalemia. And what is a cardiac myocyte with funny channels instead of IK1 and no sodium channel activity? A pacemaker cell. Obviously, if the whole heart started depolarizing to this extent, it would not be compatible with life. You would see broad QRS and then sine wave and asystole like you see with hyperkalemia. But there might be ischemic regions of myocardium that are pathologically depolarized, and those can be foci of abnormal automaticity. Now for some examples. This is multifocal atrial tachycardia. It's a significant differential diagnosis for a narrow complex irregular rhythm. It's classically seen in patients with pulmonary disease, particularly those treated with beta agonists or theophylline. It's generally thought of as an automatic arrhythmia, but the mechanism is not fully understood. There are latent pacemaker sites throughout the atria that could be enhanced through disease and sympathomimetic stimulation. The other possibility is that it is triggered activity from atrial EADs, since these would have similar predisposing factors. In any case, the treatment is primarily to address the underlying cause. Junctional rhythms can occur as a physiological escape rhythm due to the failure of higher-level pacemakers, but this example is an accelerated junctional rhythm due to increased automaticity exceeding that rate of the sinus node. We know that because it's unusually fast, and we can also see P waves at the lower rate. The junctional rhythm is causing AV dissociation like you see with ventricular tachycardia, and there are some capture beats with a fixed interval after some of the P waves. This tracing was from a case report of a 12-year-old with myocarditis following some anti-arrhythmic drugs that were given for rate control. Usually the most important interventions are to address the underlying cause. This is an example of accelerated idioventricular rhythm. It's relatively similar to the previous ECG with sinus capture beats, except the competing rhythm is coming from the ventricle. This example is from a marathon runner with elevated vagal tone and sinus arrhythmia. This could also almost be considered a ventricular escape rhythm due to sinus bradycardia, but most definitions would consider an escape to be below 50 beats per minute, and this ventricular rate is just below 60. Above 120 and a ventricular rhythm is considered a ventricular tachycardia. This is a very useful distinction because automatic ventricular rhythms, which are typically less than 120 beats per minute, do not require emergent treatment, whereas other types of ventricular tachycardia, which are almost always faster than 120, do require treatment. The most common clinical setting to encounter AIVR is as a reperfusion rhythm after myocardial ischemia. Finally, this quite rare but very interesting automatic rhythm is known as parasystole. It is the result of abnormal automaticity due to depolarization of ventricular tissue, except the depolarization also causes a surrounding partial conduction block, which insulates it from capture by the faster sinus rate. Unlike ventricular ectopics due to reentry or triggered activity, there is no relationship between the timing of sinus and ventricular beats. And unlike other automatic rhythms, it doesn't need to be faster than the dominant rhythm, they just occur in parallel. In this example, you can look at the P waves and determine that the sinus rate is regular and about 75 beats per minute. We can see one of them is a fusion complex with between ventricular and supraventricular beats. The relation between ventricular complexes isn't immediately obvious, but all of the intervals are multiples of the same underlying ventricular rate, which equates to about 53 beats per minute. For the missing ventricular beats, the exit side must have been refractory at the time. Chapter 6. This is our last arrhythmia mechanism, reentry. It's probably the most dangerous mechanism because reentrant tachyarrhythmias tend to be more stable than automatic and triggered activity. Even for triggered arrhythmias like torsades and CPVT, reentry is generally responsible for the final common pathway of ventricular fibrillation and death. Reentry basically requires two things: some kind of functional obstacle to re-enter around, and an effective one-way conduction block to initiate the circuit. As I mentioned in Chapter 1, the spatial wavelength needs to be short enough to leave an excitable gap, or the wavefront will catch up to its own trailing edge and terminate itself. I'm going to start with a classic example of anatomical reentry. This is an example of AV nodal reentry tachycardia, the most common cause of paroxysmal SVT. It's regular, narrow complex, about 145 to 150 beats per minute, and there are no sinus P waves and, importantly, no flutter waves. But if you look at the J point in V1 and V2, you can see small positive deviations which are actually retrograde P waves. This is a simplified circuit for AV and RT. Around the AV node there's a fast pathway and a slow pathway, and both can conduct in either direction. For this type of reentry to occur, the fast pathway should have a longer refractory period, and the slow path should have a shorter refractory period. If you want to remember this, you can picture a speedboat that has a very long wake behind it, and a slower sailboat has a short wake. The most common type of AV NRT is called slow-fast, which means the impulse travels down the slow pathway and then back up the fast pathway, which will be demonstrated here. First, for a normal sinus beat, the wavefront conducts down both pathways, but doesn't make it all the way down the slow pathway because the impulse from the fast pathway loops around and terminates it. For the arrhythmia, it's going to start the same, but there'll be an ectopic beat that occurs when the slow pathway is already excitable and the fast pathway is still refractory. First you have the sinus beat, and then you have the ectopic now, and now it's going down the slow and back up the fast and looping continuously until a well-timed ectopic beat collides with the fast pathway while the slow pathway is still refractory, which terminates the rhythm. That's just going to happen now. Then the sinus node takes back over. You can look at the ladder diagram to see exactly where the conduction is going on at various points. The P stars are the two ectopic beats, and the upgoing retrograde P waves can be seen as negative deviations, this time on the ECG. This form of reentry is relatively delicate because if one of the two pathways is temporarily blocked, it will terminate the rhythm, as opposed to something like atrial fibrillation, for example, which doesn't have that vulnerability. In that example, the timing of the ectopic beats and the refractory period of the pathways created a transient one-way conduction block, but there are ways to have relatively fixed one-way conduction. I'm going to illustrate this with the concept of sources and sinks. It's time for another hydraulic analogy. When a myocyte membrane depolarizes, it jumps up to a higher voltage, and we can call this the source. For the depolarization to propagate, the source needs to move charge to its neighbors through gap junctions. The neighbors are called the sink. The change in voltage for a given charge is determined by the capacitance, and if the total capacitance of the sink is too large relative to the source, it will attenuate the voltage so that the signal cannot propagate. In some situations, that's a good thing. You don't want the random depolarization of one cell to depolarize the entire myocardium. In this case, you had one source going into 6 sink cells, so it was unsuccessful. What if we made the source larger? Now if you look at the connecting arrows, each source cell is only going to an average of 2 sink cells. This means that when the charges flow, the sink cells are able to reach threshold voltage and the signal can propagate. Under certain circumstances, there can be a favorable source-sink relationship in one direction, but unfavorable in the opposite direction. First, we're going to have a large wavefront coming from the right. When it hits this choke point of scar tissue, even though there's a single source cell, it's only supplying 2 sink cells, so the signal can continue. And you can see it as it expands into the wedge, the ratio stays the same. What happens if it comes from the other direction? This time it easily propagates 2 to 1 through the wedge, but when it emerges on the other side, there's one source to 4 sinks, and the signal terminates. This one-way mechanism could easily lead to re-entry without the need for ectopic beats and refractory tissue. If the scar also has areas of slow conduction, this will shorten the average wavelength and allow for an excitable gap. This is an unusual ECG for this presentation. It's a STEMI. This section is about the anatomy and electrophysiology of scar-related ventricular tachycardia. I talk about acute management extensively in Chapter 9. This topic is very much the territory of cardiac EP specialists. I'm going to link Joshua Cooper's YouTube channel. He can explain these concepts in much more detail, but I'm going to go through some of the basics. Now, to get a scar, we need to start with an infarction. This is our mature scar. It consists of bright islands of dead myocardium surrounded by viable but potentially damaged myocardium. Scars can take various forms based on the original insult. This will be a general schematic. For clarity, I'm going to display it like this. So why does anyone care about the exact anatomy? You can terminate these rhythms acutely and suppress them with medications, but if it's a reentrant tachycardia with a fixed anatomical substrate like scar-related VT or atrial flutter, then catheter ablation can potentially cure it. The main difficulty is that you need to know which part to ablate. So how do they do it? A multipolar EP catheter looks something like this. Each metal bit is an electrode which can be used on their own or in pairs. The electrodes can be used to detect electrical activity as well as for pacing. They often use multiple catheters at once. It's done in a specialized fluoroscopy lab similar to coronary angiography. Catheters can take electrical readings from fixed anatomical sites or over a specific area for mapping. The readings look like this. The top 3 traces are just ECG traces stretched out at a slower speed. The remaining 4 traces are intracardiac electrograms. These measure electrical activity at one spot on the myocardium itself. These can give a huge amount of information based on the timing, morphology, and voltage amplitude for the various locations. To start with, remember the electrophysiologist doesn't know what the scar looks like, but they can measure electrical amplitudes at various locations. This can be done in sinus rhythm. Dead tissue won't have a voltage, damaged tissue might have a low voltage, and the mapping software can combine the readings into a voltage map. This gives a much better idea as to where the damaged tissue is, but not much functional information about the arrhythmia. Bear in mind this is a nice, clear, idealized scar with real anatomy and limitations of measurement. You might have a voltage map that looks more like this. So how do they know what to ablate? The gold standard is something called entrainment mapping. Unfortunately, it does require the patient to be in VT at the time. While we're at it, there's some specific terms used for various possible sites around the scar. There's our ECG showing VT and some electrogram readings. It's slightly on the slower side, fortunately, with a rate of 138 and an RR interval or tachycardia cycle length of 435 milliseconds. Step 1 is to put the catheter somewhere in the scar and start pacing slightly faster than the VT. One thing that can be measured here is the time from the stimulus to the QRS complex, because that is the conduction time from the catheter to the exit site if it's within the scar. It has achieved entrainment if there is capture at the faster pacing rate. Basically, this means it's still following the same pathway, but it's skipping part of the excitable gap for each cycle. Once the pacing stops, you can measure an important value called the post-pacing interval. The post-pacing interval is the time from the last pacing spike to the next detected electrogram from the VT restarting. The PPI is critical because it's used to decide whether the catheter is currently on part of the arrhythmia circuit. We can see it isn't, it's on a bystander pathway. Ablation would be useless there. If it was on the loop, the post-pacing interval would be the same as the tachycardia cycle length because it's just the time for it to loop back around. Instead, if it's here, there will be a lag from the last pacing signal to reach the circuit and then from the next tachycardia signal to reach the catheter. So it's longer than the tachycardia cycle length. There can be more than one loop, and depending on which is dominant, ablating the inner loop might do nothing or it might just change the rate slightly. The only sure way to ablate the tachycardia is to find the common pathway or isthmus and ablate that. Don't worry, there's an algorithm for this. Step 1 is to decide, is there visible fusion on the trace? In this case, no, the pace beats are the same as for the VT. If there was a different fusion morphology, the stimulus would be outside the scar. Then it asks, is the tachycardia cycle length significantly shorter than the post-pacing interval? Which is asking, is it on the loop or outside the loop? For this site, the difference is about 60 milliseconds, so no, it's an adjacent bystander, keep moving. What about here? So this has the same post-pacing interval, but now there's fusion on the trace, which means it must be a remote bystander instead. What about here? Post-pacing interval is now the tachycardia cycle length, so it's on the circuit, but there's fusion, which means it must be on the outer loop. The last box is for concealed loops, but there's one more step. If there's no fusion and a short post-pacing interval, but the QRS time is also relatively short, it is at the exit site. If the SQRS time is between 30 and 70% of the cycle length, congratulations, you're at the isthmus and you can ablate there. And then if it's more than 70%, you've gone too far and it's on the inner loop. We've now covered most cases of monomorphic VT, but there are a couple more polymorphic ones. I'm finally back to finish talking about functional reentry from Chapter 1. As I suggested then, reentrant polymorphic VT is most likely to originate on the trailing edge of a ventricular action potential wavefront. But not all ventricular muscle is the same. It's a heterogeneous 3D structure. For a normally conducted supraventricular beat, the depolarization arrives via the His-Purkinje system and then activates the ventricular wall starting with the subendocardial tissue and moving out. Then, due to differences in action potential duration, repolarization happens mostly in the opposite direction. Now let's see that on the wall itself. It starts with the Purkinje fibers, depolarizes inside out, and then repolarizes outside in, with the M cells and the Purkinje fibers being the last to repolarize. Now the key concept here is that of transmural dispersion of repolarization, which some have related to QT dispersion on the ECG. Spatial dispersion of repolarization is a more general term if you wanted to apply it to another site like the RV outflow tract rather than across the ventricular wall. The theory is that if there's heightened heterogeneity of repolarization, this could create a transient functional block for a premature impulse that leads to spiral wave reentry within the ventricular wall, leading to a reentrant polymorphic VT. This is thought to be a factor in how torsade transitions from the EAD triggered phase into the more sustained reentry phase. The premature impulse doesn't even need to be from within the heart. A non-synchronized pacing spike or cardioversion in the wrong phase can trigger VF. Even a blunt impulse to the chest during the wrong 10 to 20 milliseconds during the upstroke of the T wave can lead to VF. This is known as commotio cordis. That time window only makes up about 1% of the cardiac cycle, and the impact needs to be directly over the heart, so it's a sign of horrifically bad luck. About 75% of cases are associated with sports, usually in children and young adults. You could categorize the cause of arrhythmias as on a continuum of purely electrical to purely structural, with another axis as congenital to acquired. For example, commotio cordis is a purely acquired electrical problem, as would most arrhythmias from toxins or electrolyte disturbance. In the other corner, we could have scar-related VT, which is an acquired structural problem. Familial long QT syndrome is a congenital electrical problem, and it's thought that even drug-induced long QT might have some genetic susceptibility. We can put ARVC in the top right, and our next topic, Brugada syndrome, probably belongs somewhere in the middle top. It is a channelopathy, but it does seem to have some structural elements as well. This is a classic type 1 Brugada pattern on ECG. You can mostly see the morphology in the ST segment and T waves in V1 and V2. The T wave and ST segment result from ventricular repolarization, and specifically that transmural heterogeneity which I just talked about. Let's make that V2. Unfortunately, the exact mechanism by which Brugada syndrome causes arrhythmias and the ECG pattern are not completely understood. We know it involves a loss of function mutation in the fast sodium channel, and there are two theories at the moment as to how. They are known as the depolarization and repolarization theories. Let's start with the depolarization theory. This one focuses on the role of sodium channels in myocardial conduction. It proposes that the disease causes a marked conduction delay, leading to a severely delayed action potential and even depolarization failure in the RV outflow tract. The ECG findings would result from a large differential between the right ventricular outflow tract and the rest of the right ventricle. There is evidence that isoprenolone is protective in Brugada syndrome, possibly by augmenting conduction if this theory is correct. The repolarization theory also focuses on the RV outflow tract, but specifically the epicardium versus the endocardium. The epicardium of the RVOT has a prominent transient outward current in phase 1. With impaired sodium current, the this dominates and creates the abnormal action potential with a deeply sunken phase 1. In some epicardial cells, it's thought that the action potential collapses completely, repolarizing before it even has a proper phase 2. This could also explain the ECG findings and suggests a possible unique mode of reentry. The extreme transmural heterogeneity could give rise to reentry within the same wavefront, as the much shorter action potential is no longer refractory, while the other action potentials are still in the phase 2 plateau. Interestingly, quinidine is known to be protective in Brugada syndrome despite being a sodium blocker. Other class 1A drugs like argmolane are known to exacerbate Brugada syndrome, but it's thought that the beneficial effects of quinidine is through its inhibition of the transient outward current, which would fit nicely with the repolarization hypothesis. Isoprenolone would likely benefit in that case by augmenting the calcium current in phase 2. It is quite possible that the actual process is some combination of the two. Polymorphic VT, specifically reentrant polymorphic VT, as seen in Brugada syndrome, is on a continuum with ventricular fibrillation, and that's how it causes sudden cardiac death. I'm going to end this chapter by looking at fibrillation specifically. Fibrillation doesn't necessarily require the degeneration of spiral wave reentry. Any sufficiently rapid stimulus can lead to wave breaks in a vulnerable substrate. Atrial action potentials have significantly shorter duration, making reentry easier. Atria also have thin walls and are more likely to deform and expand over time, particularly in valvular heart disease. As a result, atrial fibrillation is thankfully more common than ventricular fibrillation. It's a heterogeneous condition that may result from degeneration of more organized reentry or even from sustained focal sources with fibrillatory conduction, which I'll discuss shortly. This ECG does show atrial fibrillation, but those additional broad complexes indicate something more concerning. This patient has an accessory pathway. Those aren't polymorphic ventricular ectopics, they're fusion complexes due to simultaneous conduction down both pathways. When seen in sinus rhythm, they're called delta waves, but have a more uniform morphology because the timing is consistent. So why is this a problem? Because of the short atrial action potentials, atrial fibrillation can lead to depolarization rates of atrial cells between 350 and 600 beats per minute. AV node conduction typically maxes out somewhere between 200 and 300, depending on the patient, but accessory pathways are made of atrial tissue, so they're going to conduct randomly, potentially over 300 beats per minute, directly to the ventricles. This ECG is showing a higher proportion of conduction down the accessory pathway. This is a critical diagnosis that you shouldn't miss. It's irregular with varying QRS morphology, but the morphology is a spectrum between one broad complex and a narrow complex due to random fusion of the two pathways. The reason you need to identify this rhythm is because most anti-arrhythmic drugs cause AV nodal blockade, and that would kill this patient. Small warning for some flashing lights in a moment. This is what conduction looks like in a patient with normal atrial fibrillation and so-called rapid ventricular response. The AV node is doing its best conducting some of those random impulses from the atria, but it might only be conducting a third of those. Because the ventricles are otherwise electrically isolated from the atria, we only see activation via the conducting system. If we add an accessory pathway that's going to want to depolarize just like the rest of the atrial tissue, well over 300 beats per minute, and now it's competing with the impulses from the AV node and conducting system. If we give the patient a drug like amiodarone or a beta blocker for rate control that blocks the normal conduction, it's only going to leave activation via the accessory pathway. Ventricles can't conduct impulses anywhere near that frequent, but they'll have a go. The wavefronts can't maintain their integrity, and instead they just degenerate into ventricular fibrillation. I made a higher resolution excitable medium simulation specifically to model fibrillation due to increased frequency of stimuli. It starts with a normal, safe depolarization, but as the frequency increases, the action potentials try to shorten to maintain their integrity, but eventually they just break apart. I've heard of this described as fibrillatory conduction. Clinicians sometimes pace a patient's ventricle at around 200 beats per minute to induce dysfunction and reduce motion during delicate cardiology procedures like a TAVI. This is usually safe. On the other hand, electrophysiologists occasionally need to induce VF, for example, to test an implanted defibrillator. This can be done by pacing directly on the T-wave to create spiral reentry and polymorphic VT. Another reliable method is very rapid ventricular pacing at the equivalent of 600 per minute or faster. The myocardium doesn't know which impulses to conduct and it just degenerates into noise. I do hope that this ECG was obtained retrospectively because that's a long time to watch someone in cardiac arrest without intervening. There's only one reliable treatment for VF, and that's old Sparky here. The mechanism of electrical cardioversion or defibrillation is complicated, but essentially it depolarizes a significant fraction of resting myocardium, putting it into a refractory state that interrupts reentry circuits. Generally, it's more effective with greater doses and it's probabilistic. If one shock doesn't work, the next one still might. It only works for arrhythmias where the current problem is reentry. You shouldn't shock a rhythm due to automaticity, such as sinus tachycardia, AIVR, or multifocal atrial tachycardia. You're just going to look silly and upset the patient. As a general rule, if the rhythm keeps appearing and disappearing, it's not going to do very much good to shock them because it might not be reentrant and it's just going to come back. For polymorphic VT due to triggered activity, so catecholinergic polymorphic VT or torsades, there are other first-line treatments and it will probably resolve. If the rhythm is sustained and they lose output, they may have transitioned into reentrant polymorphic VT, which is effectively VF, so you need to shock them. If the patient has a pulse, for example with a monomorphic VT, then remember to sync before you deliver each shock, and it's probably worth giving some analgesia or sedation beforehand as well. Before we get to drugs, I couldn't discuss the causes of arrhythmias without mentioning the effects of electrolyte disturbances and ischemia. Starting with the most obvious one, potassium. The potassium concentration gradient determines the resting membrane potential and is critical for repolarization. If you increase the extracellular potassium concentration, even just by shifting it out of cells, it will make the equilibrium potential more positive, causing the resting membrane to depolarize. As discussed in Chapter 2, this traps sodium channels in their inactivated state, decreasing membrane excitability and conduction velocity. Hyperkalemia also upregulates IKR and IK1 function, shortening the action potential. You can see this on a representative action potential that the slope of phase 3 is also now more vertical. This likely contributes to the characteristic peak T waves. The AP shortening and decreased conduction velocity reduce the spatial wavelength, potentially leading to reentrant arrhythmias. Membrane depolarization can also lead to abnormal automaticity, but the deadliest effects of hyperkalemia are all related to the sodium channel blockade, leading to conduction blocks, bradycardias, and eventually asystole. This is the same ECG from Chapter 2 with typical features of moderate to severe hyperkalemia. And this is an even more severe example. The rhythm is slowing down, becoming wider and amorphous. This patient had a potassium level of 8.2, but it doesn't always correlate. Obviously, this is a peri-arrest rhythm, but patients can decompensate relatively quickly, for example, due to cardiogenic shock or if they became drowsy with respiratory acidosis. Apologies for the complexity here, but hyperkalemia is the most proarrhythmic electrolyte disturbance for a variety of mechanisms. Firstly, the equilibrium potential is hyperpolarized. This should be logical. It shifts the phase 4 potentials down in most cells. This enhances the fast sodium current, which increases conduction velocity and excitability. Because charge follows sodium, the hyperpolarization initially enhances NCX in the forward direction, which decreases intracellular calcium. In atrial myocytes, this and enhanced ultra-rapid potassium current shorten the action potential, which can lead to non-equilibrium reactivation of sodium channels and a unique late phase 3 early after depolarization. Elsewhere, one of the most significant effects of hypokalemia is downregulation of the sodium-potassium ATPase. This inhibits NCX through their coupling via intracellular sodium levels, increasing intracellular calcium in non-atrial myocytes, and this effect becomes sustained due to positive feedback from calmodulin-associated kinase. Hopefully the next bit is familiar from chapter 4. This leads to sarcoplasmic reticulum calcium overload and spontaneous release, which causes delayed after depolarizations. Hypokalemia also downregulates multiple potassium channels, especially IKR. Now we're on chapter 3, decreased repolarization reserve, increased action potential duration, and our regular phase 2 early after depolarizations. The ion channel effects also predispose to functional reentry, which leads to atrial and ventricular fibrillation. But that's not all. There is an unassuming background potassium channel called K2P1 or TWIC, and in the presence of hypokalemia, it changes its ion selectivity from just potassium to also start conducting sodium like it's a funny channel. This causes about 45% of myocytes, notably Purkinje fibers, to paradoxically depolarize. This causes abnormal automaticity and patches of heterogeneous slow conduction, which further worsens the risk of reentry. Hypokalemia causes arrhythmias via essentially every mechanism, even inventing some novel ones. If there was a drug that just pushed your patient's potassium into the high normal range and kept it there, it would be the best antiarrhythmic we have. You could give it to every heart failure patient with their diuretics. This patient had a potassium level of 1.7. Severe hypokalemia leads to some pretty unmistakable ECG findings. You just need to recognize the pattern. There is QT prolongation associated with downsloping ST depression, with the T waves merging into giant U waves that almost reach to the next P waves. Look at the rhythm strip, how the QRS are normal, but their baseline has this sinusoidal curve to it. You just need to recognize this pattern. It's an ECG that says I'm going to develop a scary ventricular arrhythmia if I don't get some potassium. There's only one thing that looks anything like hypokalemia on an ECG, and that's the digoxin effect. It makes sense. Hypokalemia, a lot of its harm is by inhibiting the sodium-potassium ATPase. If you see an ECG that looks like digoxin effect with a long QT and they're not on digoxin, then check their potassium. You should probably also check their potassium if they are on digoxin, because hypokalemia worsens digoxin toxicity, just like hyperkalemia would worsen sodium channel blocker toxicity. Next is calcium. Hypercalcemia makes the calcium equilibrium potential slightly more positive, but this is probably of minor significance. It does have an interesting effect on fast sodium channels. It moves the voltage threshold for activation more positive, which decreases excitability. This reduces conduction velocity because each of those dominoes falls very slightly later. When we give calcium in hyperkalemia, it improves sodium channel function because their inactivation was due to their more positive voltage. Calcium moves the threshold even further positive and further away from their current voltage, which prevents activation and allows them to stay closed. Since NCX depends on concentration gradients, hypercalcemia impairs calcium efflux, increasing intracellular calcium, potentially leading to SR overload, calcium release, and DADs. Hypercalcemia has an odd effect on L-type calcium channels. They actually inactivate faster due to calcium-dependent inactivation. This, combined with NCX, decreases and shortens the action potential duration. The shorter AEP wavelength can increase the potential for reentry, and there's also increased dispersion of repolarization, potentially leading to functional reentry, as seen in Brugada syndrome. It's interesting that loss of function mutations of the L-type calcium channels can cause short QT syndrome and may contribute to Brugada syndrome. This is an ECG from a patient with a total calcium level of 6.1 millimoles per litre secondary to hyperparathyroidism. It was taken shortly before a VF arrest. It has a bizarre morphology with a short QT interval and a Brugada-like picture in V1 and V2. The effects of hypocalcemia should now be relatively predictable. It also acts on the sodium channel, making the threshold more negative, which increases excitability and conduction velocity. It enhances NCX in the forward direction and augments L-type calcium channels, leading to prolongation of the action potential and phase 2 EADs. The main ECG finding in hypocalcemia is QT prolongation, particularly in the ST segment with a relatively normal T wave due to calcium's role in the plateau phase. Finally, we have magnesium. While it has minimal direct contribution to ion currents or the membrane potential, it has countless intracellular functions, being a cofactor in almost every reaction that involves ATP. It also inhibits nearly all phase 2 and phase 3 ion channels, both depolarizing and repolarizing. Overall, it has a stabilizing effect and can be used as an anti-arrhythmic drug at supraphysiological levels. Therefore, while hypokalemia is the most pro-arrhythmic electrolyte disturbance, hypermagnesemia is the least. Elevated magnesium augments the sodium-potassium ATPase, leading to mild hyperpolarization. This augments the NCX in the forward direction, lowering intracellular calcium. It augments PMCA and particularly inhibits L-type calcium channels, which further reduces intracellular calcium. Overall, it usually shortens the action potential, and like calcium, it moves the sodium threshold more positive. This reduces excitability and conduction velocity, especially when combined with hyperpolarization. The reduction in wavelength could potentially lead to reentrant arrhythmias, but its main effect of hypomagnesemia is inhibiting triggered activity via EADs, which makes it the treatment of choice for torsades, as well as DADs. Therapeutic magnesium concentrations for arrhythmias and preeclampsia are between 1.7 and 3.5 millimoles per litre. Skeletal muscle weakness and sedation develop around 5, with coma and bradycardia in the 6 to 10 range, and cardiac arrest apparently over 12.5, which is typically asystole. I haven't found a tachyarrhythmia where magnesium is harmful, though guidelines advise it shouldn't routinely be given in cardiac arrest. It should also be used with caution in patients with renal dysfunction, myasthenia gravis, and at those at risk of conduction blocks. The antidote for magnesium toxicity is generally IV calcium. This ECG has typical findings for hypermagnesemia, sinus bradycardia with a first-degree AV block. It does vary between patients. I once had a patient develop a junctional rhythm after bumping their magnesium level to 1.7, though I suspect this was multifactorial. For a more extreme example, this is from a patient with a magnesium level of 8.2 after being given magnesium sulfate as bowel prep despite renal dysfunction. They have a borderline first-degree AV block and some more significant repolarization abnormalities. Hypomagnesemia mostly just has the opposite effects. It lowers the threshold voltage for sodium channels, increasing excitability and conduction. Regarding membrane transporters, it inhibits sodium-potassium ATPase, leading to membrane depolarization and amplifying the effect on sodium channels. This indirectly inhibits NCX, leading to increased intracellular calcium. Hypomagnesemia also impairs PMCA function and augments L-type calcium channels, further increasing intracellular calcium. I didn't mention before, but magnesium also inhibits ryanodine receptors, so when deficient, this plus the intracellular calcium overload overall leads to DADs. Again, in the opposite fashion to before, With hypermagnesemia, the action potential duration is prolonged, leading to phase 2 EADs. As you might expect, hypermagnesemia primarily manifests on the ECG as QT prolongation. The last metabolic topic relates to cellular respiration. Cardiac muscle is constantly metabolically active and obligately aerobic. ATP is primarily used for ion pumps such as the sodium-potassium ATPase, SERCA and PMCA, as well as myosin cycling. When the myocardium is deprived of perfusion or simply oxygen, transporters like the sodium-potassium ATPase pumps are unable to function, leading to disruption of the usual sodium and potassium gradients. Intracellular acidosis during ischemia and reperfusion can lead to further sodium influx via the sodium-hydrogen ion exchanger. Disruption of the potassium gradient leads to marked membrane depolarization. Reversal of NCX and failed efflux leads to a huge increase in intracellular calcium, leading to DADs and even cell death, which causes more local hyperkalemia. One defense against the effects of ischemia and hypoxia is the ATP-sensitive potassium channel, which opens in response to adenylate energy charge, shortening the action potential duration and reducing oxygen demand. The severe depolarization of ischemic tissue inactivates fast sodium channels, reducing excitability and conduction velocity. It can also lead to abnormal automaticity. Sodium channel inactivation can lead to heterogeneous slow conduction and functional reentry. Cell death is associated with adenosine release, which can act on nearby adenosine A1 receptors, though the cells are also likely responding to opposing sympathetic stimulation. I'll illustrate what's downstream of these in the next chapter. The ECG findings in hypoxia and ischemia are greatly influenced by whether it's global or regional ischemia, or even if it's transmural or subendocardial. In regional transmural ischemia, as seen with a coronary occlusion, the depolarization and plateau phases take place relatively normally, as the plateau voltages are all around the same height. However, during repolarization, the resting membrane potential is depolarized, so the vectors are abnormal relative to non-ischemic tissue. The resulting depression of everywhere but the ST segment shifts the electrical baseline, causing the characteristic ST elevation. It was quite difficult finding example ECGs that weren't more indicative of regional perfusion defects. I was able to find 2 separate cases of patients in their 20s with accidental carbon monoxide poisoning that included ECGs. This one shows a sinus tachycardia with mild diffuse ST segment depression. The second patient instead had mostly lateral ST elevation as well as a sinus tachycardia, both recovered without evidence of significant neurological or cardiac damage. Finally, this unfortunate patient had multi-organ dysfunction as well as severe aortic stenosis. During an episode of acute hypotension, they developed these ECG changes due to global coronary ischemia. The pattern resembles that seen in severe triple vessel disease or left main coronary artery disease. Chapter 8, finally, anti-arrhythmic drugs. Now, where else could I start? In 1970, pharmacologist Miles Vaughan Williams presented a rudimentary scheme to classify anti-arrhythmics. Did you know it only started with 3 categories? The first class was drugs that directly affected depolarization, such as quinidine. The second was described as drugs with anti-sympathetic action, such as propranolol. And the third were drugs that prolonged the action potential, such as amiodarone. This stuck around unchanged for about 14 years, despite the discovery of new agents, until Miles himself revised the scheme to the more familiar 4 groups. We just have to ignore the fact that quinidine is also a potassium channel blocker, propranolol is also a sodium channel blocker, and amiodarone belongs in all 4 classes. Out of curiosity, how would that Venn diagram look? probably something like this. I wouldn't call this definitive because the effects are classified as present or not present for the Venn diagram rather than a continuous quantitative affinity in reality. The 1984 revision also split class 1 into 3 subcategories, but out of what I could only assume was malice, he put them in the least intuitive order possible. With that, we have the categories most of us saw in textbook, often with magnesium, adenosine, and digoxin tacked onto the end. We might as well add isoprenolone or isoproterenol there as well. In 1991, Rosen and Schwartz made a valiant effort to modernize this classification with an array that would show multiple properties and effects of each agent. Unfortunately, human brains don't work like that. I don't want to be too harsh, but it pretty much defeats the point of having a system at all. You still have to memorize the individual properties of each drug. Thankfully, in 2018, a century after the birth of Vaughan Williams and only 2 years after his death, Lay et al. From the University of Oxford published a more systematic and comprehensive revision, which I will be using in this video. There is now a class 0 for the completely novel ivabradine, which inhibits the funny current. There's also a 4th sodium channel blocker subgroup, which includes ranolazine. I think the most useful and interesting change is subcategorizing class 2 into various autonomic modulators with beta blockers as class 2A. Suddenly we have a place for most of our miscellaneous drugs, and I'll elaborate on these shortly. Class 3 was also subdivided to make room for non-voltage gated potassium channel modulators like nicorandil. Class 4 was subdivided to include both surface, membrane, and intracellular calcium channels. For example, both class 1C drugs also block the ryanodine receptor, which is a calcium channel. Now, this isn't official, but I would personally add poor neglected magnesium here because it's one of the safest and most versatile antiarrhythmics, and if you could give it a single mode of action, it is a calcium channel blocker at least. They also sensibly put in placeholders for anticipated mechanisms without current examples, for example, mechanosensitive ion channels blockers or gap junction channel blockers, like a bupropion overdose, but useful. Finally, we have upstream target modulators. There is lots of drugs like ARBs and statins that protect against arrhythmias indirectly, but that's much too long term for my critical care attention span. I kind of love the idea of ivabradine. All it does is slow down phase 4 depolarization, decreasing normal automaticity and slowing down the sinus rate, typically by about 10 beats per minute at rest. Its usefulness as an antiarrhythmic probably depends whether you think relative sinus tachycardia is an arrhythmia. It's used as an anti-anginal because oxygen demand is so closely tied to heart rate, and it's also used to aid filling in certain patients with heart failure, assuming they wouldn't tolerate further beta blockers. It's also used off-label for POTS. It's hepatically metabolized, and the main adverse effect appears to be bradycardia, shockingly, with cases of sinus arrest in large overdoses. I'll come back to it as a reference point in the next chapter. Moving on to class 1, the sodium channel blockers. I was pretty happy with this sodium-specific color scheme, but for clarity, I'm going to briefly increase the contrast so you can tell different waveforms apart in the next slide. I'll start with a quick overview of the subclasses based on their effects on the action potential. I'll go in the original arbitrary order since it's still how they are classified. Class 1 agents are the moderate sodium channel blockers. They reduce the phase 0 slope and prolong the action potential duration. Note, for illustration purposes, I have exaggerated the effects on phase 0 by at least an order of magnitude. These drugs can produce a measurable effect on QRS duration, but that is due to the cumulative effect of countless phase 0 delays. They prolong the action potential because all class 1A agents also inhibit IKR, a class 3 effect. This is because they don't bind to sodium channels with particularly high affinity and IKR is relatively susceptible to inhibition. Class 1A includes quinidine, an alkaloid from cinchona bark, which is one of the oldest antiarrhythmic drugs. It still has a few uses due to its unique antiarrhythmic profile with effects on multiple ion channels, including potent blockade of the phase 1 transient outwards current. Unfortunately, it has many adverse effects, including vomiting and diarrhea in about a third of patients. It can also cause hemolysis, thrombocytopenia, other immune-mediated reactions, and a neurological syndrome known as synchronism. It can also cause torsades in about 1 to 3% of patients. It inhibits CYP2D6 and P-glycoprotein, with the latter causing severe interactions with digoxin. Procainamide was developed as a possible replacement for quinidine and, internationally at least, remains one of the more commonly used 1A agents in the acute setting. It does have significant longer-term toxicity, including a lupus-like syndrome in 20 to 30% of patients and more severe hematological toxicity than for quinidine. Diisopyramide has fewer idiosyncratic side effects but causes the worst anticholinergic effects of the 1A agents and marked negative inotropy, leading to it being contraindicated in systolic heart failure. It is sometimes used in hokum as a negative inotrope. Finally, argmaline is mostly used in Europe. It's another plant alkaloid, this time from Indian snake root, that also gave us reserpine. It's very short-acting with a half-life of 5 minutes and is only given intravenously. Historically, it's been used to provoke the Brugada ECG pattern in suspected cases. As mentioned, tricyclic antidepressants are similar to 1A antiarrhythmics as well. Class 1B agents are very different to 1A and 1C. They barely have an effect on phase 0 of the action potential. The only significant effect on the action potential is they reduce its duration by inhibiting the late sodium current and tipping the balance towards repolarization. The best known example is the local anesthetic lidocaine. Lidocaine is lipophilic with easy mucosal absorption but has very high hepatic extraction ratio, which prevents it from being orally bioavailable. It's very safe when dosed appropriately, but at progressively toxic levels produces a neurological prodrome, followed by seizures, then circulatory collapse and asystole. You can think of mexiletine as simply oral lidocaine. It's used for long QT syndrome type 3. Its main side effects are GI and neurological. The anticonvulsant phenytoin is also a 1B antiarrhythmic, which has been around longer than lidocaine. It also has significant GI and neurological side effects, notoriously unpredictable kinetics, and is difficult to administer IV, so has fallen out of use as an antiarrhythmic. Toconide is another 1B agent that was been withdrawn, and amiodarone sodium channel blockade is similar to that of a 1B agent. Class 1C are the scary ones. As with all antiarrhythmics, the dose makes the poison, but these are really effective poisons. They just block sodium channels potently and with slow dissociation. This means they prolong phase 0 but have little other effect on the action potential. Flecainide is the prototypical 1C drug. Propafenone is less potent and generally less effective than flecainide, and also has a mild beta blocking effect. Other examples include cocaine, several withdrawn antiarrhythmics, and a fairly new mystery one that I'll discuss later. The revised classification also gave us class 1D. So far it only contains one drug, ranolazine, which is also used as an anti-anginal and preferentially inhibits the late sodium current like a 1B agent. It effectively is just an atypical 1B agent, except it also blocks the IKR potassium channel, which cancels out the shortening effect on the action potential. The biggest problem I have with the ABC classification is the order. I know they were arbitrarily labelled in a time when the molecular mechanisms weren't understood, but I'm still allowed to complain. In terms of phase 0 slowing, The order BAC would seem to be the most logical, and that also relates to the weak, intermediate, strong potency and the as well as the speed of association of fast, intermediate, and slow. Even if you did use the original metric, which was the effect on action potential duration, the order would still be wrong. My advice would be to not think of these as a spectrum, but as distinct categories from each other. Anyway, that's enough of the high contrast. I'm now going to discuss why these three main subclasses behave so differently. To properly understand why, we need to take a closer look at the fast sodium channel and its three main states. This is a slightly more realistic view than our simplified schematic before. Remember that the channel has an activation gate shown in red because it is closed, an inactivation gate at the bottom shown in green because it is open. This means that the channel is in its closed or resting state, which can only happen when the membrane is polarized. I want you to think of the whole channel as a compressed spring. The positive charges above are pressing the two red positive sections down and towards each other. The negative charge below is also keeping that green inactivation gate away from the pore. When the membrane depolarizes, that energy is immediately released and the activation gate swings open. Simultaneously, the inactivation gate starts to swing closed, so the channel inactivates after 1 to 2 milliseconds. The channel can only re-enter its closed state when the membrane repolarizes and those charges are back. Those are our three physiological states. Remember, the channel is only conducting sodium ion current in that brief open state. To better illustrate the process, I'm going to use a whole bunch of white dots to represent a population of receptors. In phase 4, all of the channels are in the closed state. When the membrane depolarizes, they rapidly spring open and then immediately the inactivation gate swings shut. In that time, they've managed to completely depolarize the membrane through sodium influx, but the inactivation process isn't perfect. Perhaps 1 or 2% of the channels can flick back into the open state during the plateau phases 1 and 2. This allows a much smaller late sodium current to last far longer than phase 0. It's not as dramatic as the phase 0 spike, but overall it can allow a similar total sodium influx simply due to the much greater time it exists for. Remember, an abnormal sodium receptor that increases the late current is responsible for the long QT syndrome type 3 by tipping the scales away from the repolarization reserve. An exaggerated late current can also be seen in ischemia and with CAMP and calmodulin kinase mediated signaling, where it can lead to EADs by increasing intracellular sodium in a similar fashion to digoxin. Once the membrane repolarizes due to potassium efflux, the channels are able to re-enter the resting state. This delay is responsible for the refractory period because the cell cannot depolarize again until all the channels have reset to their closed state. Now that would be all of our states, but remember this is a talk on pharmacology. So there are 3 more possible states. There are closed with drug, open with drug, and inactivated with drug. These are in an equilibrium with the non-drug states when a drug is present and can transition between each other in a similar fashion to the non-drug states. Of the 6 states, the only one that can conduct a sodium current is the non-drug open state. Now I can show you how the 3 main subclasses affect the receptor, and let's start with the most interesting one. Class 1b drugs have very little affinity for receptors in their closed state. They have a small affinity for the open state, but this is so brief they can't really have much effect. They have the highest affinity for the inactivated state, shifting a bunch of these receptors from I to ID. But how is that pharmacologically useful? Neither I or ID conduct a sodium current, so how would moving between them affect the membrane potential? They affect it by abolishing part of the late sodium current. Because there are less transitioning between I and O states, this leads to their only significant effect on the physiological action potential, which is shortening its duration. The opposite fashion to how long QT3 lengthens the action potential. This is why mexilotine is used to treat long QT syndrome type 3. Once the membrane repolarizes, almost all of the drug rapidly dissociates from the receptor, though if the heart rate is fast enough, a couple might remain. This is one way they can have a minor effect on phase 0, and it's the mechanism for so-called use dependence with the other two classes. Because class 1b agents mostly bind to channels when they're inactivated during the plateau, logically they work best when there is a long plateau phase. For example, in ventricular myocytes and Purkinje cells, class 1b agents have essentially no effect on atrial or accessory pathway myocytes because their action potentials are so much shorter. You might think that this late sodium current makes them pretty niche, limited to conditions like long QT3 and digoxin toxicity, but there are a couple more possible indications. Class 1b agents are thought to be significantly more effective at slowing conduction in damaged or ischemic tissue. If myocytes are partially depolarized during phase 4, then many of their sodium channels are inactivated rather than in their closed state, and the 1b agents can therefore bind, potentially even affecting phase 0. Since they have almost no effect on conduction in healthy tissue, have little use dependence, and they shorten the action potential, from a pharmacodynamic and pro-arrhythmia point of view, the class 1b agents are almost certainly safer, if not as potent, as class 1a and 1c. Next we have class 1a, the medium group. Despite associating slower, they have a much higher affinity for the open state and can have a significant effect on phase 0. They also have a decent affinity for the inactivated state, so stay associated during the longer plateau phase, and take longer to dissociate than class 1b when the membrane repolarizes. If a channel is in the CD state when the next action potential arrives, it will move to OD, and OD does not conduct sodium. This gives them the property that's useful for tachyarrhythmias, use dependence, also known as rate dependence. The longer the RR interval, or specifically the TQ interval, when the membrane is polarized, the more time for the drug to dissociate. Conversely, the faster the rate, the greater the effect of the drug. Class 1a drugs primarily inhibit the peak current. All class 1a agents inhibit the inactivated state, so the reason class 1b are so specific for the late current is because they mostly lack an effect on the peak current. You could treat long QT with a giant dose of flecainide, for example, but you'd then have other problems. Why do class 1a prolong the action potential? Because they only have medium affinity and they also block potassium channels. This gives them more power to terminate reentrant rhythms and counters the effect on spatial wavelength that I'm about to discuss for class 1c, but it does have a specific pro-arrhythmia risk, and that's torsades. Quinidine was so notorious for causing torsades it had a specific name, quinidine syncope. Interestingly, the torsade risk is highest at low to therapeutic doses, because at higher doses the sodium channel effect predominates. Tricyclic antidepressants best resemble 1A antiarrhythmics during cardiac toxicity. Due to their anticholinergic effects, the ECG and severe toxicity may resemble VT, but it's more likely to be a sinus tachycardia with prolonged conduction. The rationale for using lidocaine as an adjunct in TCA toxicity is based on its faster association and dissociation, potentially displacing the more toxic agent. This is somewhat analogous to pyridostigmine pre-treatment before a nerve agent exposure, if you saw my neuromuscular junction video. You should never give a sodium channel blocker in hyperkalemia, even a 1B agent, since there's nothing to displace. All you can do is worsen their sodium conductance and possibly stop their heart. The more traditional 1A drugs also have anticholinergic side effects, which are particularly marked for disopyramide. still significant for quinidine and less so with procainamide. Muscarinic blockade can increase AV nodal conduction, which might be problematic in atrial fibrillation or flutter. Finally, we have class 1C, the pure, very potent, somewhat scary sodium channel blockers. These slow phase zero conduction even at rest because they even have a small affinity for the closed state. They have about equal affinity for the open and inactivated states, but because they associate more slowly, this is more pronounced for the latter. The slow dissociation gives them marked use dependence. Flecainide therapy is expected to increase the baseline QRS duration by 12 to 20%. More than 25% has recommended the drug be discontinued because it's possible for conduction to worsen further in a use-dependent fashion, even with simple exercise. The QRS widening does result from the decrease in the slope of phase zero, but the change on the action potential would be almost imperceptible. The QRS effect is due to the cumulative effect on conduction velocity from each affected channel, as seen with the dominoes in Chapter 2. This hyperkalemia-like mode of action could be useful in specific circumstances, like if you wanted to block an accessory pathway without affecting nodal tissue, but it did make me wonder how these drugs actually work to terminate AF, for example. So I went back to the fibrillation simulation from Chapter 6 and added a potent use-dependent phase zero block. As you can see, it nearly terminates the arrhythmia immediately just through suppression of depolarization, but something really interesting happens to the surviving wavefronts. If you compare to with and without drug, the spatial wavelength was obviously longer before, and the leading edges were in more danger of colliding with the trailing edges ahead of them. Wavelength is refractory period duration times conduction velocity, so if AP duration is basically the same and the conduction velocity decreases, then the wavelength will get shorter. Look at all the space it has now. You've slowed down the speed of the fire, but the fuel has more time to grow. Wouldn't this potentially make reentry worse? Unfortunately, the answer is yes. You may have heard of the infamous CAST trial. In the late 80s, due to concerns that for ventricular ectopic beats precipitating arrhythmias after MI, it was hypothesized that suppressing those depolarizations with a class 1C agent might reduce the incidence of sudden death. The trial was stopped early because the rate of death in the 1C group was more than twice that of placebo. Most deaths were due to arrhythmias. Since then, class 1C have been blacklisted for patients with ischemic heart disease or cardiac failure, those at highest risk of reentrant ventricular tachycardia and resulting sudden cardiac death. There's one more interesting pro-arrhythmic effect with class 1C. This is atrial flutter with a mostly 2-to-1 block. It's narrow complex, about 150, and you can see the sawtooth appearance in the inferior leads with distinct additional atrial waves in V1. I mentioned that a drug like quinidine with anti-muscarinic effects and no AV nodal blockade could accelerate the rate of AV nodal conduction, potentially increasing ventricular rate of AF or flutter. Class 1C agents like flecainide have minimal effect on the AV node but can cause a similar problem, particularly with flutter. In the atria, flutter is a regular macro-reentrant rhythm that tends to have a cycle length equating to about 300 beats per minute. In adults, under usual conditions, the AV node can't conduct 300 beats per minute, so it tends to ratchet down to the next option, a 2-to-1 block. You can see this on the ladder diagram. It's like clockwork, only every second action potential is conducted because the others are refractory. I'm going to slow the animation down to 1/5 so it's a bit easier to see. If we give this patient flecainide, it won't have any effect on the AV node, but it will affect the atrial conduction velocity. Say it slows the rate down to 200. Wait, why does the monitor look like that? The AV node couldn't conduct at 300, but it can actually manage 200. So we've managed to convert an atrial rate of 300 with 2-to-1 conduction to a rate of 200 with 1-to-1 conduction. A ventricular rate of 200 is a lot harder to tolerate than 150. Class 1C agents should be avoided in atrial flutter, and if they're used for AF, it's often recommended that the patient also be on an AV node blocker. Speaking of AV nodal conduction, we're up to class 2, the autonomic modulators. You might not be used to having drugs other than beta blockers here, but I promise it makes sense, although I'm not the biggest fan of presenting them as 5 arbitrary letters. Instead, think of them as 3 axes. Yes, I've added a 6th one now. Let's just call that caffeine. Notice now that we've got slow, fast, slow, fast, slow, fast. You've probably worked out that these are pairs of agonists and antagonists for the same G-protein coupled receptors. For beta adrenergic receptors, we have the beta blockers as antagonists naturally, and the opposing inotropic and chronotropic agents, isoprenolone, dobutamine, and adrenaline, as agonists. Atropine and glycopyrrolate inhibit muscarinic receptors, increasing heart rate and conduction, while digoxin indirectly increases parasympathetic stimulation, and agents like methacholine stimulate the receptors directly. Adenosine and ATP stimulate A1 receptors with similar effects to acetylcholine. Finally, caffeine and theophylline antagonize adenosine A1 receptors, although they also inhibit phosphodiesterase intracellularly. In practical terms, caffeine and theophylline are mostly used to provoke tachyarrhythmias in the EP lab. Muscarinic and adenosine agonists have niche uses to slow the AV nodal conduction. Atropine and glycopyrrolate are used to reverse vagally mediated bradycardias, usually sinus or Mobitz 1 block, or as antidotes to cholinesterase inhibitors. Isoprenolone is probably the most effective chemical chronotrope available and is anti-arrhythmic under very select circumstances. Adrenaline and dobutamine are mostly used for hemodynamic support, and finally, beta blockers are easily the most important anti-arrhythmics in terms of safety and overall mortality benefit. These opposing relationships continue on the intracellular level. These are our 3 receptors in their natural environment, all G-protein coupled, 1 stimulatory and 2 inhibitory, along with their endogenous agonists. Both G-protein pathways converge with their respective effects on adenylyl cyclase and CAMP formation. CAMP directly modulates the Funny channel and phase 4 depolarization in nodal tissue, and the inhibitory receptors also activate a potassium channel which has various names. It's known as KACH for acetylcholine, KADO for adenosine, or by the name of its protein subunits GERK1 and 4 for G-protein coupled inward rectifier potassium. That channel is only present in the atria and nodal tissue. Adenosine can affect ventricular tissue through adenylyl cyclase inhibition, but its effects are more subtle. For example, it can inhibit DADs, but only those due to sympathetic stimulation. The other downstream effects are mediated by CAMP activating protein kinase A. pKa augments IKS, shortening the action potential in tachycardia, and indirectly stimulates the sodium-potassium exchanger, preventing intracellular sodium overload like we saw in Chapter 4. It stimulates voltage-gated sodium and calcium channels, as well as the ryanodine receptor and SERCA, augmenting both sarcoplasmic calcium release and reuptake. pKa also phosphorylates myosin-binding protein C, augmenting contractility by enhancing cross-bridge turnover, and troponin I, which reduces myofilament sensitivity for calcium. This improves relaxation at the cost of contractility. That negative inotropy is easily overcome by the increase in intracellular calcium flux. There is a significant amount of crosstalk and amplification between signaling pathways. For example, CAMP via EPAC stimulates the 3rd G-protein coupled receptor pathway, Q11, calcium signaling. With prolonged and repetitive calcium signaling, the calcium and calmodulin activate the calmodulin-associated kinase, which further stimulates most of the same targets as pKa. Calmodulin kinase is heavily implicated in arrhythmias and cardiac failure, but this is a difficult pharmacological target due to its essential function in non-cardiac tissues. This is about as deep as I'm going to go with intracellular signaling, but we can now see where other drugs act. For example, adrenaline is like NORAD but with more beta agonism. There's also isoprenaline with just beta agonism and the beta antagonists. Digoxin's inotropic and pro-arrhythmic effects are direct, but its AV node blockade is neurally mediated by sensitizing baroreceptor afferents. There are also direct muscarinic agonists and antagonists, and then the methylxanthines inhibit A1 and receptors and phosphodiesterase, and we also have some of the channel blocking antiarrhythmic drugs just for completeness. In case the complexity of the previous image was bothering you, we can see the same drug and signaling interactions here, this time only concerning action potentials in nodal tissue, along with the direct-acting ivabradine and calcium channel blockers. I'll talk a little bit more about distinctions between nodal blocking agents, including their anti-inotropic effects, shortly at the end of this chapter and in chapter 9. I'm now going to talk about individual beta blockers. I'm sure you will have come across big tables with weird terms like ISA or membrane stabilization, so hopefully this should make it all a bit more clear. I'm using another Venn diagram, but it won't be as complicated as the last one because we're just looking at one set, which is the contents of this red circle, drugs which are antagonists for the beta-1 adrenergic receptor. Many of them are specifically considered inverse agonists, but that distinction is a little technical for this discussion. The first subset to consider are drugs that are also antagonists for the beta-2 adrenergic receptor. Typically, these subsets are known as non-selective beta blockers, while drugs that block beta-1 and not beta-2 are considered cardioselective. It's somewhat arbitrary distinction because all have some affinity for beta-2, but the cardioselective ones are orders of magnitude more selective for beta-1. A good conceptual comparison would be to look at beta adrenergic agonists. Now you have a traditional intersecting Venn diagram for beta-1 and beta-2. The blocker Venn diagram is nested because we don't have any pure beta-2 antagonists because the main effect would be causing bronchospasm, and that's not especially useful. We could call beta-1 agonists cardioselective, and the best example would be dobutamine, which we use as an inotrope in intensive care. We could call an agonist for beta-1 and beta-2 non-selective, and the natural example would be isoprenaline or isoproterenol, which is used as a chronotrope and in specific cases to induce or treat particular arrhythmias. Before we had selective beta-2 agonists, it was also used to treat asthma, both systemically and via inhalation. Specific beta-2 agonists we could call lung selective, and that would include salbutamol, also known as albuterol, Ventolin. The best example of a non-selective beta blocker, an antagonist for just beta-1 and beta-2 without additional effects, is nadolol. Nadolol is the drug of choice for patients with congenital long QT syndrome and catecholaminergic polymorphic VT. We don't normally use it in Australia, but it gets special approval for these arrhythmia syndromes. The heart has beta-1 and beta-2 receptors, especially around the SA node, which is why isoprenaline is a more effective chronotrope than dobutamine, and nadolol is a more effective anti-chronotrope and antiarrhythmic than a so-called cardioselective agent. A disadvantage of the non-selective agents is a higher chance of off-organ side effects, particularly bronchospasm in patients with asthma. There is evidence that non-selective beta blocker administration does increase airway resistance in the short term and may decrease the potency of rescue salbutamol therapy, though chronic therapy with escalating doses of even non-selecting beta blockers seems to be well tolerated in most patients with mild to moderate asthma or COPD. There is even some evidence that chronic therapy, particularly with nadolol, might be beneficial in asthma due to biased second messenger effects. Beta blockers do save lives, and most of the time the biggest threat to life is chronic cardiac disease, but in a few patients there's acute severe asthma, so you need to do a risk-benefit assessment. Our next subgroup is going to be beta blockers that are also sodium channel blockers, sometimes vaguely referred to as membrane stabilizing activity. Our one example is also a beta-2 antagonist, which is why it's within both the red and blue regions. Propranolol was the first widely used beta blocker, and it is the other agent commonly used to prevent arrhythmias in long QT syndrome. Its sodium channel blockade provides a small additional class 1 antiarrhythmic effect. It's about 4 to 5 times shorter acting than nadolol, so it needs to be given 3 times a day for arrhythmia prevention. This is why nadolol is preferred, because maintaining consistent drug levels is so important, and frequent dosing decreases patient adherence. The other major difference between the two is that propranolol is one of the most lipophilic beta blockers, while nadolol is one of the least. I'd suggest you watch my political compass video for more detailed explanation, but for practical purposes this means that propranolol has significant CNS penetration and, like most beta blockers, is hepatically cleared, while nadolol, sotalol, and atenolol are renally cleared. The CNS penetration explains propranolol's preferred use in some anxiety disorders. There's also a non-selective beta blocker with additional potassium channel blockade, specifically the delayed rectifier IKR, which makes it both a class 2 and class 3 agent. I'm obviously talking about sotalol, which might be the only beta blocker that's exclusively used as an antiarrhythmic. Sotalol is a racemic mix of D and L enantiomers. The L isomer blocks beta 1 and beta 2 adrenoreceptors and the IKR potassium channel, while the D isomer is just a potassium channel blocker. As mentioned, it is hydrophilic, renally cleared, and can be given orally or IV. I'll talk about sotalol a little more with the other class 3 agents. Next, we have two agents that block beta 1, beta 2, and alpha 1 adrenal receptors, giving them vasodilator effects similar to prazosin. Carvedilol is mostly used in heart failure and has afterload reduction. Carvedilol is also used to treat portal hypertension in patients with cirrhosis. Propranolol and nadolol are also used, but it needs to be a non-selective agent because the effect is via beta-2 antagonism. Vasodilating beta blockers may also be preferable in patients with arterial insufficiency or Raynaud's phenomenon. There's also the shorter-acting labetalol. Labetalol is one of my favorite beta blockers. You can give it oral or IV. It's perfect for almost every hypertensive emergency besides cardiac stuff like APO. So preeclampsia, neurosurgery, even aortic dissection, because it doesn't cause a reflex tachycardia. It's not used as much as an antiarrhythmic though. You want something with less vasodilation probably. That brings us to the cardioselective agents, which just means they're beta 1 and not beta 2. From longest acting to shortest, we have bisoprolol, commonly used in heart failure. Then we have atenolol, which also benefits from once daily dosing, but tends to be less popular because it's renally cleared. Metoprolol might be the archetypal cardioselective agent. It's very versatile in acute medicine because it's medium duration of action for easy titration, and it can be given IV or orally. The oral form is about 50% bioavailable. Obviously, like with opioids or anything with a clear dose-response relationship, an IV bolus will have a sharp peak and must always be given in smaller increments than the enteral doses. Giving these drugs IV is almost always safer than enterically if you know what the dose is, because you will see the peak effect within minutes and you can give small amounts until the desired effect is achieved. All beta 1 antagonists are negative inotropes. Remember, they're the opposite of dobutamine, so if you're unsure about someone's cardiac function, giving 2.5 milligrams IV is much safer than giving 25 orally, because you can't take that dose back if they decompensate. I have seen a patient die after they were given 50 milligrams of oral metoprolol for rapid AF without knowing they were on the verge of cardiogenic shock. Larger oral doses will also have a longer duration of action, so you might want to give it once you've seen how they respond to the IV dose. What do you do if you are concerned that the patient has brittle hemodynamics and needs a beta blocker? That brings us to the ultra short acting agent esmolol and the even shorter acting agent landiolol. These are rapidly hydrolyzed into inactive forms by esterases in the blood like clovidipine or remifentanil, which means they can be given as a titratable infusion, making them ideal for critical care. Finally, we have two agents that are selective beta-1 agonists plus plus an additional effect. We have a unique agent, nebivolol, which stimulates endothelial nitric oxide synthase, making it a vasodilator via a different mechanism to carvedilol, although it's also used for heart failure. While nitric oxide production is a downstream effect, it is thought that nebivolol achieves this by being an agonist of the beta-3 receptor on endothelial cells. Our last group are beta-1 partial agonists, sometimes referred to the unnecessarily oblique term intrinsic sympathomimetic activity. This means that they provide some low-level stimulation at rest but block excessive stimulation in an analogous fashion to buprenorphine on the opioid receptor. The advantage of partial agonism is that they may be better tolerated by patients who would otherwise develop bradycardia or hypotension. I've listed acebutolol as an example here. We don't actually use it in Australia, but I needed an example. Labetalol might have some partial agonism as well. Acebutolol is sometimes used as an anti-arrhythmic and, interestingly, for ischemic heart disease despite its partial agonism. It also has some sodium channel blocking activity, but not as significant as propranolol. So if you wanted, you could amend the Venn diagram to bridge those groups as well. Sometimes the beta blocker is divided into three generations. The first generation are the beta-1 plus beta-2 plus or minus ion channel blocking agents. The second generation are the beta-1 or cardiospecific agents. And then the third generation are beta blockers with vasodilatory activity plus or minus beta-2 activity. That's it for Class 2. On to Class 3, potassium channel modulators. This category now has multiple subdivisions for voltage-dependent, metabolically dependent, and transmitter-dependent. 3A can be subdivided based on the particular channels involved. Amiodarone is the most notable Class 3 agent by far, and it will have its own detailed discussion shortly. A major part of its efficacy is that it's not a specific potassium channel blocker, and it also has Class 1, 2A, and 4A activity. Its non-iodinated derivative dronedarone also spans multiple classes, but it's not as efficacious or versatile as its parent drug. As I've mentioned, sotalol is a non-selective beta blocker with additional Class 3 activity. Unfortunately, it's associated with a significant and dose-dependent risk of torsades, affecting about 2% of patients overall with oral use. D-sotalol, its non-beta blocker isomer, has been studied on its own as a pure Class 3 agent, which just seemed to make it even more pro-arrhythmic with less benefit. After the 1996 SWORD clinical trial in post-MI patients was terminated early due to increased mortality in the D-sotalol group, it seems to have mostly disappeared. Ibutylide and dofetilide are mostly pure IKR inhibitors that have stuck around. Ibutylide is shorter acting, tends to be given IV, while dofetilide is usually given orally. Like sotalol, about 2% of patients on oral dofetilide will develop torsades. The risk is even worse with IV ibutylide, with about 4% of patients developing torsades, most commonly right after the original tachyarrhythmia was terminated. Then we have vernaculant, which inhibits the ultra-rapid delayed rectifier channel. Now this is a smart idea. The ultra-rapid delayed rectifier channel is the reason that the atrial action potential is shorter than the ventricular one. It's only found in the atria. If you block that, presumably you have the perfect drug for, say, cardioversion of AF without any dangerous ventricular side effects. Vernaculant was claimed to be that drug. First thing to note is that it doesn't just block IKR-UR. It's actually a multi-channel blocker, also inhibiting IKR plus the transient outward channel like quinidine and IK-ATP, which is another atrium-specific channel. It also has some sodium channel blockade. That's not necessarily a problem. Many of our best drugs are multi-channel agents, so why aren't we using it in Australia or the United States? For a start, it doesn't work that well. It's fast, and converted about 50 to 70% of patients, which is reportedly more effective than ibutylide or dofetilide, but less effective than flecainide and propafenone. But class 1C agents are dangerous, causing ventricular reentry and conduction block and cardiovascular collapse if you're not careful. That sort of seems like overkill if you just want to treat AF with it. Vernaculant was pitched as a safe and convenient alternative, but the FDA was skeptical of these claims and asked for another trial before it was approved. A patient in the treatment group unfortunately died, and the trial was cancelled and never published, and the approval was denied. I thought this all sounded a little bit suspicious. Why did they ditch this promising drug after a single adverse event? And then I noticed all of the papers singing its praises had financial ties to Merck or Cardiome, the manufacturer. I did some digging to find out what the FDA actually said about the drug, and it was scathing. The FDA ignored the manufacturer hype, looked at its pharmacological profile and safety data, and concluded that vernaculant is not a unique class 3 agent that only works on the atria. It's primarily a class 1C anti-arrhythmic that's similar to flecainide. They reported it's not atria specific, it also affects the ventricles. Quoting directly, it prolongs the QRS, markedly so in some subjects, is a negative inotrope in dogs and humans, and has caused deaths in dogs and humans. They also stated that vernaculant has induced harm that cannot be reliably predicted, prevented, or treated in some cases. In contrast, electrical cardioversion and ibutylide pharmacologic cardioversion can cause adverse events that are transient or treatable. One of the panelists was quoted as saying, "In order to take a risk, there has to be a clear benefit. Here, there is a risk of a very infrequent but fatal catastrophic event. What's the advantage? It's convenience." So nice work, FDA, and that's not to say that we'll never find an agent that fits this niche. Moving on, there's another category for the metabolically dependent K-ATP channel, which I mentioned in the ischemia hypoxia section. Nicorandil stimulates this current, which is part of its mode of action as an anti-anginal. There's also a space for the transmitter-dependent KACH or GERK channel, but we don't currently have any directly acting agents. Some drugs like adenosine and digoxin stimulate it indirectly through its physiological pathway, but those are in subcategories of class 2. Finally, there are lots of other channel blocking antiarrhythmics that inhibit potassium channels, primarily IKR. This includes all class 1A agents, ranolazine, and even verapamil. Quite a few non-antiarrhythmic drugs block IKR as well, and we'll come back to those. The mode of action should be pretty intuitive after looking at reentry circuits. If you sufficiently prolong the action potential, specifically the effective refractory period, it will obliterate the excitable gap, and the wavefront is terminated when it collides with itself. Let's look at a more chaotic example, fibrillation. I've simulated the addition of a pure class 3 agent to the fibrillation model from before. It doesn't quite terminate, but you can see the wavefront stretched, and it's gone from having dozens of chaotic foci of functional reentry to having about 3 remaining double roses. It's sometimes called figure 8 reentry, but I think double spiral fits the appearance better. At the bottom of the screen, you can see a pretty normal looking wavefront, which shows how close it came to complete defibrillation. It's just a question of whether there's enough room left in the medium to sustain functional reentry under the new conditions. If that's the case and we're so close, why can't we just give more drug until it does terminate? Do you remember how we're prolonging the action potential? By chipping away at repolarisation reserve. Unfortunately, the longer we make it, the closer we get to the new equilibrium voltage and repolarisation failure. QT prolongation isn't just an adverse effect of these medications, it's the mode of action. All pure class 3 antiarrhythmics like ibutylate and dofetilate cause EADs and torsades as described, typically in a dose-dependent fashion. QT prolongation and torsades are also seen with certain mixed anti-arrhythmic drugs. As mentioned, sotalol is particular high risk, as well as class 1A drugs. Unfortunately, due to its molecular structure, IKR inhibition is a common side effect of many non-antiarrhythmic molecules. Since the presenting symptom is torsades and potentially sudden death, this has been responsible for a disproportionate number of drug withdrawals and scandals. Notable examples include cisapride, which has been withdrawn, droperidol, which was blacklisted despite being incredibly useful when used sensibly, and various medications that were haphazardly recommended for COVID, such as azithromycin and hydroxychloroquine, which are particularly dangerous when given together. Also, don't drink a random quantity of chloroquine from a bottle of fish tank cleaner, although this does raise an important point. The dose makes the poison. If a drug has a relatively low affinity or effect site concentration and you take too much more of it, then you'll have more of that effect. This is why people megadose on loperamide for its opioid agonism, for example, but that unfortunately also works for loperamide's IKR inhibition. This ECG is from the only patient I've seen with a clear droperidol-induced QT prolongation. They were given a total of 15 milligrams IV for agitation, which is a large dose, but certainly not unheard of. They were observed on telemetry and had no significant tachyarrhythmias. The two important factors here are dose and individual susceptibility. You're probably not going to see this giving 0.5 to 1 milligram for nausea. Individual risk factors include being female, electrolyte disturbances, heart rate, other medications, and it's suspected that there are also contributive genetic polymorphisms, even in patients who don't have a diagnosed long QT syndrome. Sometimes you aren't aware of any of those factors. Years ago, I attended a rapid response call. It was for a patient in their mid-30s after an elective abdominal surgery. I couldn't get much history because when I turned up, the nurses were doing CPR. We did a rhythm check and it was VF. We gave one shock and it reverted with ROSC and the patient woke up, GCS 15. Looking at the monitor, it was now a narrow complex rhythm, but it was slow, in the 40s, and they were having weird beats and some short runs of polymorphic VT. Being stupid at the time and not having studied this, I thought, oh no, this young patient who we just saved is going to arrest again. We should give a drug to stop that. We had amiodarone already out because of the arrest, and I figured it was a shockable rhythm. ACLS says shockable rhythms get amiodarone, so we'll give it slower because the patient has output now. We were just hanging it up when a cardiologist appeared and nearly slapped me and then stopped the amiodarone. The history that I wasn't privy to when I arrived was that the patient had a congenital complete heart block. They were never symptomatic with it and maintained a perfusing rhythm, so despite recommendations for a pacemaker, they had opted out. Years later, they were assessed for this unrelated surgery and again mentioned that they didn't want a pacemaker, and the surgery somehow went ahead. Post-operatively, they developed bradycardia and QT prolongation, and they were put on a cardiac monitor which spotted an episode of pause-induced torsades that degenerated into VF. Amiodarone was not the correct treatment. The patient got a pacemaker very shortly later and was fine. This was an acquired long QT syndrome, probably due to perioperative medication plus the bradycardia. Complete heart block is a specific risk factor for torsades. The dog study that I referenced in Chapter 3 used animals with complete heart block because it made them easier to provoke. For bradycardia or pause-induced arrhythmias, the treatment is magnesium and, if necessary, heart rate augmentation. If you want to use our best chronotrope, isopranolone, for that, you should do it cautiously. To understand why there's a little bit of nuance here, let's look at the effects of progressive beta-adrenergic stimulation on repolarization, starting with the usual wild-type ion channels. So normally at rest, there is a large repolarization reserve, mostly due to IKR, against a smaller depolarizing effect of the L-type calcium channel. If we apply a sudden sympathetic stimulus such as an alarm clock, this upregulates both the depolarizing L-type calcium channel and the repolarizing IKS potassium channel, but the calcium current kicks in faster. It's okay because we have repolarization reserve. If there's sustained sympathetic stimulation, as seen with exercise, there's a bit more of the calcium current, but all of the repolarizing IKS has time to kick in, overcoming the calcium current and shortening the action potential. Now let's look at a patient with congenital long QT syndrome type 1. This is due to a heterozygous loss of function of the Kv7.1 potassium channel, which is responsible for the IKS current. At rest, IKS only has a minor contribution to repolarization, so the action potential is relatively normal. With a sudden sympathetic stimulus, there is augmentation of the calcium current with less IKS to balance it, and the repolarization starts to destabilize. With sustained stimulation, as seen with exercise, there are maximal depolarizing currents, and the absence of IKS is the most pronounced. The patient has lost their repolarization reserve, leading to EADs. In the worst case scenario with the patient swimming, there is also vagal stimulation from the trigeminal or dive reflex, slowing the heart rate and leading to repolarization failure and torsades. What happens if we swap the loss of IKR for IKS? This patient has a loss of the Kv11.1 or HERG channel responsible for IKR. This is seen in congenital long QT syndrome type 2, as well as most cases of drug-induced QT prolongation. As you can see, because IKR is essential at rest, there is a loss of repolarization reserve even at baseline. Then what happens when we have a sudden sympathetic stimulation from an emotional shock or fire drill or alarm clock? There is immediate repolarization failure and torsades, because the calcium channel ramped up faster than IKS could compensate. This is probably also a contributing factor for cardiac arrest after inhaling hydrocarbons. The arrhythmia is usually precipitated by a sudden shock, and many of these chemicals are known to inhibit IKR. Assuming they survive the initiation, with sustained sympathetic stimulation, IKS has time to kick in and replaces IKR as the dominant repolarizing force. Realistically, you can't keep someone in a state of sustained adrenergic stimulation indefinitely. That is the very silly premise of the 2006 movie Crank. For patients with congenital long QT syndrome type 2, beta blockers are still life-saving and strongly recommended, but they're not as protective as they are for long QT type 1. For drug-induced QT prolongations, things are further complicated by the possibility of reverse use dependence. Tachycardia is somewhat protective in all cases of IKR dysfunction because of the effect of IKS accumulating with heart rate, but certain drugs, for example sotalol, have preferential binding in the closed state, which give it a stronger inhibition when the heart rate is slow. This is the last thing you want in an antiarrhythmic and makes bradycardia even more dangerous. How can you apply this? If your patient has torsades from long QT type 1, give magnesium and avoid catecholamines, no question. Consider a beta blocker. If it's long QT type 2, give magnesium and should probably still avoid catecholamines. If it's drug-induced plus they're bradycardic or the main abnormality is bradycardia, like my heart block patient, then give magnesium and they might benefit from electrical or chemical pacing, even with isopranolone. Because of the counteracting effects, you may need to individualize. For example, if you start the isopranoline and they get even more runs of torsades, then turn it off. If there's one drug in this video that warrants an in-depth discussion, it's amiodarone. Amiodarone is the clozapine of antiarrhythmics. Like clozapine, it's a very dirty drug with many pharmacodynamic effects, but those are what make it the best at what it does. It's typically a drug that's used when all others fail. Like clozapine, it has some side effects that affect everyone that takes it, plus some special idiosyncratic effects that are so dangerous that they require regular monitoring and a serious risk-benefit analysis for chronic use. We've tried to make less problematic versions, for example dronedarone, but it was never as good as the original. One distinction is that unlike clozapine, amiodarone is frequently administered by non-specialists, especially in acute and critical care medicine. Let's start with the pharmaceutics because they're interesting. I've previously made a video about how the biopharmaceutics classification system is a great conceptual model for categorizing drugs based on their physical properties, so I suggest you check that out for more detail. But in short, group 1 drugs like lidocaine or most beta blockers are easily water-soluble and lipid-permeable, which makes them ideal molecules for drug delivery. If they lack oral bioavailability, typically it's because of first-pass metabolism. Group 2 drugs, of which amiodarone is an extreme example, are lipid permeable but water insoluble, relatively speaking. They tend to have high protein binding and tissue penetration and are easier to administer enterally than IV. Group 3 drugs like atenolol or digoxin are water soluble but not lipid permeable. They're easier to administer IV and tend to be renally cleared. Group 4 is the least favourable group. It includes things like amphotericin and mannitol that are not permeable or water-soluble. To illustrate how insanely lipophilic amiodarone is, we can check its log P value, which is the logarithm of the octanol water partition coefficient. This is determined by adding the substance to a vessel containing both water and the hydrophobic octanol and measuring its concentration in each liquid. If it was equally lipophilic and hydrophilic, the log of 1 is 0. Adenosine is a hydrophilic group 3 drug and has a log P of around -2. And the famously lipophilic propofol has a log P of 3.8. Amiodarone has a log P of 7, one of the highest values I've ever come across for a drug. Because it's logarithmic, this means that amiodarone is 10 million times more soluble in octanol than water. This physical property has a huge impact on its pharmacokinetics. For a drug to be absorbed through the GI tract, typically it needs to be relatively small and lipophilic enough to diffuse through cell membranes. Amiodarone doesn't have that problem, although its bioavailability is variable and it's only between about 35 and 60%. This is because it's so hydrophobic it doesn't want to dissolve in the aqueous GI lumen and even reach the cell membranes. This is why its bioavailability is higher when it's taken with a fatty meal. What about intravenous? Well, amiodarone really doesn't like being in water. The IV form is typically prepared with more lipophilic excipients like polysorbate 80 and benzyl alcohol to keep it in solution. These additives, particularly this polysorbate 80, have a negative effect on hemodynamics, causing vasodilation and decreased contractility when given quickly. In a randomized comparison study with and without polysorbate 80, it was associated with hypotension far greater than with amiodarone by itself. This peaked at the end of the infusion, although it is worth noting the infusion rate was 5 mg per kilo over 3 minutes IV, which is much faster than the more typical 15 to 60 minutes for a large dose outside of cardiac arrest. Amiodarone also likes to leach into certain plastics, so it might require special bags and giving sets for a prolonged infusion. The IV formulation has a pH of 4 and it's irritating to veins, so should preferably be given via a central line. Once it reaches the blood, amiodarone is highly protein bound. It really hates being in water, and as soon as it gets an opportunity it escapes, mostly into adipose tissue, giving it a massive volume of distribution, estimated to be about 60 litres per kilogram of body weight. I discuss amiodarone specifically in my compartmental models video, but essentially it has such a high volume of distribution it takes a long time to get the whole body to a steady state therapeutic concentration. A typical loading dose for amiodarone for an adult might be 600 milligrams orally each day for 4 weeks, followed by a maintenance dose of 200 milligrams a day. A rapid IV infusion can briefly push the concentrations in the central compartment to a much higher than chronic therapeutic range, which might be useful to terminate an arrhythmia, for example. This doesn't cause toxicity because the infusion isn't sustained at that rate, and when it ends, the high concentration gradient causes most of the drug to disappear into the tissues. Amiodarone is metabolized by CYP3A4, and notably its des-ethyl metabolite has significant antiarrhythmic properties. Amiodarone inhibits several of the most important cytochrome P450 enzymes as well as P-glycoprotein, so it has numerous pharmacokinetic drug interactions, for example with warfarin and most other antiarrhythmics. It's ultimately eliminated in the bile, and due to its large volume of distribution and relatively low clearance, it has an absurdly long terminal elimination half-life of around 1 to 3 months. With abrupt cessation of chronic therapy, there tends to be a fall in serum concentration by about 50% over the first 3 to 10 days, followed by a very slow decay as the rest trickles back out of the tissues, which fits with the multi-compartment model. The pharmacodynamics are also interesting. In short, it blocks everything. It has sodium channel blockade that best fits a 1B agent. It causes alpha and beta adrenergic blockade, reminiscent of carvedilol, but does so in a non-competitive manner, unlike most other antagonists. It blocks most cardiac potassium channels and doesn't have the reverse use dependence seen with drugs like sotalol. This, combined with a balance across the multiple potassium channels and the fact it has class 2 activity and blocks depolarizing sodium and L-type calcium channels, means that it has the lowest torsade risk of any major class 3 agent, which is less than 1%. Amiodarone's calcium channel blockade is also minor than the other effects, and this fits with its relative hemodynamic stability. Just for good measure, it probably also inhibits the funny channel like avabradine, so we can throw class 0 up there as well. It prolongs action potential duration, slows nodal conduction, as well as fast conduction in ventricular and Purkinje cells, and reduces automaticity. Despite being generally labelled a class 3 antiarrhythmic, when amiodarone is given intravenously, the potassium channel blockade is almost negligible, with the classes 1, 2, and 4 effects being more significant. The des-ethyl metabolite has prominent potassium channel blockade, so this tends to emerge later, and it's also more prominent with oral administration due to first-pass metabolism. Overall, amiodarone is almost certainly the most effective antiarrhythmic agent. It treats most atrial and ventricular tachyarrhythmias. It's one of the safest in terms of hemodynamic stability and has a wide therapeutic index in the acute setting. It's actually rare to see serious acute toxicities from amiodarone, making it unique among antiarrhythmics. If someone takes way too much flecainide or sotalol, you're going to see a weird-looking ECG in a very unwell patient. In terms of proarrhythmia, it has that small torsades risk. It's a sodium channel blocker which can impair conduction. And it's an AV nodal blocker, so it's contraindicated in some patients with accessory pathways. Sounds great, right? Why did I leave so much room on this slide? Unfortunately, chronic amiodarone therapy is associated with a range of adverse effects involving almost every system. These range from universal and rare and from asymptomatic to lethal. I've already mentioned most of the cardiac toxicity. With chronic use, about 2 to 4% of patients have significant bradycardia, which may be sinus or AV block. One of the most distinctive systemic adverse effects is thyroid dysfunction, and all patients should have thyroid function monitored before and during long-term therapy. Amiodarone is chemically similar to thyroxine. and has a number of direct effects on thyroid physiology. It inhibits enzymes responsible for conversion of T4 to active T3, as well as inactivation of reverse T3. Amiodarone and its metabolite also interact with T3 receptor binding and with some thyroid-related gene expression. These may even have a minor contribution to its antiarrhythmic effect. With chronic accumulation, amiodarone can also have a direct toxic effect on thyroid follicular cells. The other major reason for amiodarone being associated with thyroid dysfunction is simply the amount of iodine that someone on amiodarone consumes. Those two iodines in the molecule might not look that significant, but if you factor in the relative atomic mass, amiodarone in its hydrochloride form is about 37% iodine. So it's estimated that about 10% of this is released as free iodine in the body. And at steady state, every dose taken corresponds with the same amount metabolized. So depending on bioavailability, a patient on 200 milligrams of amiodarone a day or more could be getting 50 times the recommended daily intake of iodine just from amiodarone. Iodine excess alone will cause a spectrum of thyroid dysfunction similar to that seen with the drug. The physiological response to a large iodine load is to inhibit thyroid hormone synthesis and release. This is a form of autoregulation known as the Wolff-Chaikoff effect. After 2 to 4 weeks of sustained exposure, the effect subsides and it goes back to normal production. Failure of this escape process is one cause for amiodarone-associated hypothyroidism. Hypothyroidism is more likely to occur in patients who are previously iodine replete, particularly those with positive antithyroid antibodies or Hashimoto's disease. This can be corrected with thyroid hormone replacement, but it may require higher than normal doses. Amiodarone-induced thyrotoxicosis can be divided into two subtypes. Type 1 involves unregulated synthesis of thyroid hormone in response to the iodine load in patients with pre-existing thyroid abnormalities such as Graves' disease or multinodular goiter. It tends to happen relatively early, around 3 months into treatment. It's treated with thionamide antithyroid drugs such as methimazole or PTU, followed by thyroidectomy or radioiodine ablation once the patient is euthyroid. Type 2 AIT is an inflammatory process thought to be due to a direct cytotoxic effect. It can happen in patients with previously normal thyroid and tends to happen later, around 30 months into therapy. It's usually milder and can be treated with oral steroids for 1 to 3 months based on their response. If patients don't respond to therapy, the treatment strategy for the other type may be added. Sometimes the clinical picture falls in between and they might receive steroids plus antithyroid drugs first line. If the patient's unlikely to tolerate a prolonged period of thyrotoxicosis, the fastest way to correct it is urgent surgical thyroidectomy, although the perioperative management might be physiologically challenging. It's usually possible to continue amiodarone with hypothyroidism or AIT type 2. For AIT type 1, the decision should be individualized with involvement of the patient's cardiologist. That's a thyroid, but it's not even the worst one. The deadliest toxicity from amiodarone involves the lungs. I mentioned that amiodarone likes to accumulate in adipose tissue, but the second highest concentrations are found in the lungs. This accumulation can lead to a combination of direct toxicity and inflammatory changes. As you might expect, this risk is related to both dose and duration of therapy. With current lower dosing around 200 milligrams per day, it occurs in about 1 to 2% of patients, and you'd expect to see a greater risk after about 2 years of therapy. In the past, with daily doses of 400 or more, the incidence was closer to 5 to 10%. The most common picture is an interstitial pneumonitis that can progress to pulmonary fibrosis. About a quarter present with an organizing pneumonia. Management is to stop amiodarone permanently, and most patients are given steroids. Mortality for this chronic form is around 5 to 10%. In rare cases, amiodarone can also cause an acute respiratory distress syndrome. It can occur after initiation of amiodarone or with patients on chronic therapy, and it's thought that thoracic surgery is a risk factor, but it's not well understood. Mortality for these patients is around 50%. Amiodarone can also cause a transient elevation in liver function tests in around 15 to 30% of patients, and may cause more severe hepatitis or even cirrhosis in less than 3%. Amiodarone also affects the eyes, with corneal microdeposits almost universally in patients on long-term therapy. They're mostly asymptomatic, but may cause visual changes such as halos or blurred vision in up to 6%. Optic neuropathy is more serious and can occur in 1% of patients. It affects the skin, causing photosensitivity. It can lead to a blue-grey discoloration, most prominently in the face. Non-specific gastrointestinal symptoms such as nausea, anorexia, and constipation are relatively common, as are central nervous system effects, particularly tremor, ataxia, and insomnia. It can cause peripheral neuropathy in about 0.3% of patients per year. In rare cases, it can also cause bone marrow dysfunction, such as causing pancytopenia, for example. Amiodarone can also cause epididymitis and SIADH. Maternal amiodarone has been associated with developmental abnormalities in the fetus and can cause hypothyroidism in newborns when present in breast milk. Patients need to be counselled and monitored before and during chronic therapy, including history and physical exam, ECG, blood tests for the thyroid and liver function, chest x-ray and pulmonary function tests with diffusion capacity, slit lamp and vision assessment, as well as checking electrolytes and levels for co-administered drugs like warfarin and digoxin. Overall, about 20% of patients on chronic amiodarone will stop it due to adverse effects. Why do we need to know all this? I'm interested in critical care. You're probably interested in critical care. I don't prescribe long-term oral amiodarone. I do prescribe IV amiodarone. I use it all the time, usually for rapid AF. If it doesn't work right away, they'll stay on an IV infusion either until it's no longer needed or until someone decides to switch them to high-dose oral therapy as a loading dose. I've seen some intensivists do this pretty casually. There's obvious incentives. The infusion's expensive, it needs monitoring, a central line might keep them in ICU. If you stop the infusion, the effect will dissipate because they haven't finished their loading dose. We use amiodarone because it's so effective and it tends to be the most hemodynamically stable agent for rhythm control. You could also consider it a first-line agent in the ICU. Chronic amiodarone therapy isn't first line for anything unless the patient has structural heart disease and specifically needs rhythm control. Now think about how many patients are discharged home on a PPI that was only charted for stress ulcer prophylaxis. In 2014, a hospital in Philadelphia looked at 117 patients who were studied on IV amiodarone for new onset AF in the ICU. 57% of those patients were discharged home on amiodarone. Only 61% had a cardiology appointment scheduled. Most of the cohort were non-cardiac surgical patients. I'm sure some of them just reverted at home after their acute illness, but I doubt that many had appropriate counselling and screening. Obviously, this might be less of an issue with better handover and different inpatient teams and hospital pharmacists, but I feel the ideal moment to pause and reassess the treatment strategy is when you decide to switch the patient from IV to oral therapy. It is a shame that dronedarone isn't as effective and seems to harm people with reduced systolic function. There is another analogue in development called budeodarone that kept the iodine moieties but is broken down by tissue esterases, giving it a comparatively ultra-short half-life of 7 hours. We'll have to see if it can match the efficacy of its parent with less toxicity. Now for our last major drug class, the calcium channel modulators. I'm going to focus on class 4A, which block the cardiac L-type calcium channel CAV1.2, namely verapamil and diltiazem. The other antiarrhythmic in this group is bepredil. It's an interesting one. It's a calcium channel blocker quite similar to diltiazem, but it also affects calmodulin and calcium troponin binding. It's a class 1B sodium channel blocker and inhibits numerous potassium channels like amiodarone. Unfortunately, it causes torsades significantly more frequently than amiodarone. I don't know if we need an amiodarone with less hemodynamic stability and more torsades. As a result, it's not used much anymore, although it's still used in Japan. There's also etripamil, which is still in development but can be given as a nasal spray for SVT, which is pretty cool. These drugs are on a spectrum with the dihydropyridines, since the CAV1.2 is also the major calcium channel on vascular smooth muscle. All of these calcium channel blockers inhibit vascular smooth muscle. For example, verapamil is given intra-arterially to treat cerebral vasospasm. The main distinction is that diltiazem and verapamil also have cardiac specificity, verapamil slightly more so. The mechanism is complicated, but from what I understand, verapamil and diltiazem bind at different intracellular sites, gaining access through the pore, which gives them a type of use dependence. Dihydropyridines bind extracellularly and in a voltage-dependent fashion, preferring to bind at the more positive membrane voltages of vascular smooth muscle around -60. It honestly doesn't matter for this topic because none of them have significant antiarrhythmic activity. Verapamil and diltiazem do two things. In nodal tissue, they decrease the slope of phase 0 depolarization, slowing conduction and reducing automaticity. In other fast myocardial cells, they inhibit calcium influx during the phase 2 plateau. Let's look at nodal tissue first. One more time, back to the automaticity chart. Remember, calcium channel blockers act here on the upslope of phase 0. We can compare that, for example, with ivabradine, which changes the slope of phase 4. Beta blockers do a bit of both. By only affecting the phase 0 slope, there's not as much potential to finally regulate sinus rate without abolishing it completely, but they can have a very potent effect on nodal conduction. Remember, that slope doesn't just contribute to the RR interval, it also determines the speed of conduction in slow tissue, specifically the AV node. Meanwhile, in fast tissue, they have no effect on conduction, instead inhibiting calcium influx in the plateau phase. This may have some antiarrhythmic effects, for example by reducing triggered activity, but the main effect is to dramatically impair the contractility of every working myocyte in the heart. Calcium channel blockers are most effective in their effect on slow conduction, particularly for reentrant circuits where a critical segment relies on slow conduction, or for rate controlling impulses from atrial fibrillation through the AV node. Their adverse effects relate to their mode of action. With nodal tissue, they can slow conduction excessively, leading to AV blocks, though as you can see, each sinus beat is still conducted in this case. There's often variation between patients. For this one, automaticity was completely abolished, leading to sinus arrest. There are no P waves here, and the QRS complexes are an escape rhythm from high in the His-Purkinje system. In this case, there is still automaticity because the sinus node is working, but AV conduction has been completely abolished. This patient also has an escape rhythm from below the AV node, but it's probably further down because it's broad complex. I'll mention the other main adverse effect here because it's hard to see contractility on an ECG. In fast tissue, calcium channel blockers limit the phase 2 calcium influx that tells the myocytes to contract, making them profoundly negatively inotropic. Beta blockers and amiodarone also reduce this current, but in both cases that is one of many effects. Calcium channel blockers act more like a scalpel, just knocking out contractility and nodal depolarization, and often that's not ideal. They also have extra cardiac side effects. For example, both can cause vasodilatation, diltiazem more so, and this can be associated with peripheral edema. Verapamil is also particularly associated with constipation. I also mentioned that they made some placeholder categories and listed upstream target modulators which aren't particularly relevant to the acute setting. So those are our drugs. Chapter 9. For the last major section, I'm going to tie everything together and discuss which antiarrhythmic drugs can be used for a given rhythm and how to approach the management of a patient with a serious arrhythmia. Certain antiarrhythmic drugs only work on particular tissues. You need to match the tissue tropism of the drug to the anatomy of the rhythm. Just picture the heart as having three different tissue types. There's slow nodal tissue, which are the SA and AV nodes. Next type is fast atrial tissue with short action potentials. Importantly, this also includes accessory pathways. Finally, there's the fast ventricular tissue with long action potentials, which includes the His-Purkinje system. To start, there are drugs that only affect nodal tissue. Ivabradine the obvious one. Digoxin has effects on every cardiac myocyte, but those are mostly side effects. Its only antiarrhythmic utility is indirect vagal stimulation of nodal tissue. Next, we have drugs that mostly affect nodal tissue. Adenosine is somewhat analogous to digoxin, but it also inhibits EADs from sympathetic stimulation in fast tissue. Beta blockers and calcium channel blockers work on every cell in the heart, but for an acute arrhythmia, they are mostly used for their effects on nodal tissue, for example, rate control in AF. Next group, we have drugs that work on all three tissue types. Obviously, amiodarone is in this group, as well as sotalol because it's class 3 plus a beta blocker. I'm just using one example for some classes to avoid clutter, so dronedarone also fits here, for example. Next, we would have drugs that affect both types of fast myocardium but not nodal tissue. These are class 1A and 1C because they work on sodium channels, plus the exclusive class 3 agents like ibusulide. Like with digoxin, nodal tissue also relies on IKR, and ibusulide has a destabilizing effect on nodal tissue, but that's an adverse effect. It's not clinically useful when you're picking an antiarrhythmic. Finally, there's one drug class that only works on ventricular tissue, and that's class 1B, for example, lidocaine, because they need that long action potential. Now let's see some rhythms. To start, we have sinus rhythm, an example of normal automaticity with supraventricular conduction. There can be focal atrial activity, which can be automatic or triggered. Next, we have atrial flutter, a macro-reentrant supraventricular rhythm. Importantly, the reentry circuit does not involve the AV node. Atrial fibrillation is functionally very similar. For these rhythms, drugs that affect fast tissue can be used for rhythm control, while drugs that affect nodal tissue will only slow the ventricular rate. AV nodal reentrant tachycardia is similar to flutter, except it always has one-to-one conduction, and the reentrant circuit involves a section of nodal tissue. This means drugs like adenosine can terminate the rhythm. This heart also has an accessory pathway, so potential rhythms include orthodromic AV atrioventricular reentrant tachycardia, which is a narrow complex because it travels down the conducting system and back up the accessory pathway. There's also antidromic AVRT, which does the opposite, which makes it broad complex. Other rhythms, for example, sinus or AF, can also potentially conduct down both pathways. If you wanted a drug that would only block the accessory pathway and not the AV node, it would have to come from the top right box, class 1A, class 1C, and exclusive class 3. For the scary rhythms like pre-excited AF, electricity is also an option. Moving down to the ventricles, we have reentrant monomorphic VT, which is fixed to an anatomical circuit. There can also be triggered activity, which could lead to monomorphic or polymorphic ventricular rhythms. Finally, we have the most dangerous rhythm, reentrant polymorphic VT, which can easily degenerate into VF. We can also categorize these drugs by their mechanisms of arrhythmia, and I will do that shortly, but let's take one more look at the nodal agents. I implied at the end of Chapter 9 that ivabradine and calcium channel blockers were at either end of a spectrum, with beta blockers in between, so here is that spectrum. Calcium channel blockers have a submaximal effect on automaticity, but a large effect on conduction, and also decrease contractility. Ivabradine only affects automaticity, which in practice means the sinus rate, with no effect on conduction or contractility. Beta blockers are in between, but closer to the calcium channel blockers. They have a little more effect on heart rate by reducing CIMP, and are not as negatively inotropic as calcium channel blockers. That's a spectrum for drugs that significantly affect the SA node because it has heart rate on it. But what about ones we use for AV node blockade specifically? We can also subdivide them into inotropic effect, which is handy if we wanted to rate control someone with rapid AF. AF is a fun example because almost every antiarrhythmic drug will have some effect, apart from ivabradine and possibly class 1B agents that only work on the ventricle. Adenosine could be considered neutral in terms of inotropy, but the effect is obviously transient, so unless the reentry circuit involves the AV node, it's limited to a potential diagnostic role. Another factor to consider is time to effect, with the effect being clinical rate control through AV node blockade. The more direct nodal agents have an advantage here, but risk being less hemodynamically stable. Amiodarone, despite primarily being used for rhythm control, is often a useful compromise, typically achieving a sustained rate control within 1 to 3 hours. Digoxin's onset of effect is very slow, taking at least 5 hours. What if it's new onset and we wouldn't mind rhythm control either? Amiodarone is the most likely to convert them by far, but if you need something completely hemodynamically neutral that works immediately, there's always the electrical option. We just subdivided the drugs by site and tissue specificity, which is particularly important for reentry circuits, but not all arrhythmias are due to reentry, so let's quickly look at which drugs work on various mechanisms. We can start with reentry. Potassium channel blockers like ibutilide only work on reentry, as does electrical cardioversion. The effects of other classes on reentry is going to depend on the anatomy we just saw. For example, class 1 agents cause conduction block in fast tissue, which might exacerbate reentry, or terminate it if it's on a segment of vulnerable tissue and it's blocked completely. Nodal agents do the same but for slow tissue, so the overall effect is going to depend on the anatomy. Ivabradine, beta blockers, adenosine and calcium channel blockers all suppress automaticity, but may lead to failed automaticity by the same mechanism. Beta agonists like isopranolone and antimuscarinics do the opposite. Digoxin causes abnormal automaticity as an adverse effect through membrane depolarization. Speaking of adverse effects, IKR blockers in class 3 and 1A can cause EADs and torsades. Both forms of triggered activity are suppressed by class 1B, beta blockers, calcium channel blockers, and magnesium. Adenosine and ryanodine antagonists can specifically suppress DADs, and DADs are also worsened by beta agonists and digoxin. At this point, we can consolidate some of this information into a tachycardia management algorithm. It starts with 3 simple questions. Is it narrow or wide complex? Is it regular or irregular? And is there any atrial activity visible? This gives us 4 starting categories. For regular narrow complex tachycardia, there are 3 broad possibilities: sinus, various forms of SVT, and atrial flutter with a constant block. You should be able to distinguish sinus if P waves are visible, but if it's very fast, this might be difficult. A useful rule of thumb is that the fastest sinus rate a person can reach is around 220 minus their age. If it's faster than that, it's probably SVT, and if it's right on 150, it might be flutter with 2-to-1 block. There's also 3 main possibilities for an irregular narrow complex rhythm: atrial flutter with variable block, atrial fibrillation, and multifocal atrial tachycardia. Wide complex means that the ventricles depolarize at a slower rate than usual. This is either due to abnormal conduction or the rhythm originating within the ventricle. For wide complex rhythms, I always want you to think first about 3 important pitfalls that might get you into trouble if you just assumed it was VT. They all start with P for pitfall. First question, is this rhythm physiological? Bundle branch blocks are relatively common, so any of the narrow complex tachyarrhythmias could be wide complex if it was combined with a bundle branch block. Just quickly, this is how I remember the typical morphology. A left bundle branch block, the QRS is going to look like a deep V in V1 and an RSR M shape in V6. Meanwhile, a right bundle branch block, the QRS will have an M shape in V1 and an abnormally long S wave in V6. Therefore, I remembered these as Mrs. Valium. It just fit the best. If it helps you to think of the Rolling Stones song Mother's Little Helper, then I guess it's an option. What do I mean by is it physiological? I looked at data from patients presenting to 2 different emergency departments with wide complex tachycardias, and in both cases about 70 to 75% were either sinus tachycardia with a bundle branch block or atrial fibrillation or flutter with a bundle branch block. Even for AF, the majority were not presenting due to the tachycardia. It was secondary to something else. Many patients have chronic AF and their AV conduction responds to autonomic inputs. So you can essentially think of it like their sinus rate. A cohort study in 2 Canadian EDs found that patients with AF or flutter plus an acute underlying illness, specific efforts at rate control or rhythm control were associated with an almost 6-fold increase in adverse events compared to just treating the underlying illness. Unlike SVT with bundle branch block, you can often distinguish sinus rhythm, AF, or flutter with a bundle branch block from something like VT. I would consider this pitfall to also include any other automaticity related rhythms like MAT that are usually secondary to other factors. If it's physiological, do nothing, treat the cause. The second pitfall question is this pre-excitation? Just like a bundle branch block causing a wide complex, an accessory pathway can do the same thing, although these can behave very differently to their narrow complex counterparts. The simplest is just sinus tachycardia with an accessory pathway, manifesting as a fusion complex or delta wave. You just manage this like sinus rhythm. The next one is antidromic atrioventricular reentrant tachycardia with a very broad rapid complex that is indistinguishable from VT on an ECG. Finally, on the irregular side, we have the extremely life-threatening pre-excited atrial fibrillation that I discussed in Chapter 6. The safest option for both of these is electrical cardioversion, but especially for pre-excited AF, you can't use any drug that blocks the AV node, including beta blockers, calcium channel blockers, amiodarone, adenosine, or digoxin. Last pitfall. Is this poison or potassium? These are patients with sodium channel blockade due to drugs or hyperkalemia as discussed in Chapter 2. The treatment first line is IV calcium and sodium bicarbonate. And finally, we have the ventricular rhythms, of which there are 3 broad categories. On the regular side is one more pitfall, accelerated idioventricular rhythm. This is due to abnormal automaticity, usually associated with reperfusion, and should be treated as physiological by doing nothing. You can distinguish AIVR by its rate. It's going to be going less than 120. By definition, a regular ventricular rhythm above 120 is a monomorphic VT. Ventricular rate can be incredibly useful for telling some of these apart. Just remember the numbers 120 and 200 or over 200. If your broad complex rhythm is less than 120, it's too slow for VT. And you should think of physiological rhythms like sinus or AIVR, as well as poisons and potassium. Once it's approaching 200, it's also unlikely to be sinus. The other value to look for is the QRS duration in milliseconds. Conveniently, the values to remember are the same. More than 100 is abnormal, but over 120 is significant. If it's much over 200, you should be wondering, is this too wide for VT, especially if the rate is on the slower side. After these three pitfalls, there is just one last step in the algorithm. Treat it as VT. To summarize management for when the diagnosis is known, if it's physiological, do nothing, treat the cause. If you know it's SVT, then you can use the usual vagal maneuvers. Adenosine may be a calcium channel blocker if it's narrow complex. If it's AF or flutter, and their primary problem is the arrhythmia, then you can use cardioversion, especially for flutter, or the usual drugs for rate or rhythm control, and think about anticoagulation. Wide complex tachycardia with pre-excitation, electrically cardiovert them. Your only drug options are 1A, 1C, and ibusilide. Remember, 1B doesn't work on atrial tissue. Poisons and potassium. You give calcium and bicarbonate to everyone. It won't hurt, it might save them. There are some further steps if you know the toxin. Monomorphic VT, over 120 beats per minute. Cardioversion is first line, but if they're stable, you could potentially use procainamide or amiodarone. Polymorphic VT is most likely acute ischemia or torsades. Cardiovert them if sustained or unstable, and then treat accordingly. If this seems too simplistic, don't worry, I have a whole slide subclassifying VT that coming up. You might have noticed a small problem here. How do we know what the rhythm is if they all look the same, or if they look the same? Well, if it's completely regular, moderately wide complex with a rate in the 160 to 200 range, you usually can't distinguish SVT with bundle branch block, antidromic AVRT, and monomorphic VT. So just assume that they're all monomorphic VT. Electrical cardioversion is safe and effective for all of them. Let's look at a case. A 78-year-old woman with a history of atrial fibrillation and COPD presents to the emergency department with generalized weakness, nausea, and shortness of breath. She had a normal blood pressure and her pulse was 80 and irregular. After a few hours, she gets an ECG which shows this. What the hell is that? The heart rate's normal, and the BP is okay, but we can see it's obviously still not right. So let's put it into our tachycardia algorithm. It's an irregular, extremely broad complex rhythm with relatively consistent QRS complexes with some variation. If we said that these aren't dramatically polymorphic, it would probably fit best with atrial fibrillation and some kind of aberrant conduction. It's too slow to be VT. It's not even technically a tachycardia. Plus, it's too wide to be a VT. The QRS duration is 400 milliseconds. So what do we think of if it's too slow and too wide to be VT and it looks weird, toxic and metabolic? If you ever see a patient with this ECG, give them calcium and sodium bicarbonate IV immediately. A patient with this ECG could go asystolic at any time. It's going to be hyperkalemia or possibly a sodium channel blocker, and this will treat for both. Turns out in this case the potassium was normal, but her medication list included flecainide. Why was a 78-year-old woman on flecainide? She'd had multiple hospital presentations with symptomatic AF and a failed ablation, so based on her preferences and after screening for ischemic and structural heart disease, her cardiologist chemically cardioverted her and sent her home with regular verapamil plus an oral flecainide to be used as a pill in the pocket strategy. Unfortunately, prior to her presentation, she'd had a COPD exacerbation for which she was taking salbutamol, and that was giving her palpitations, so in a further act of self-medication, she would take an extra flecainide each time a home pulse oximeter showed that her heart rate was over 100. This worked out to 900 milligrams each day for a week. After they discovered the toxicity, she was moved to a monitored bed, and her team called a toxicologist. The toxicologist told them to give sodium bicarbonate and calcium, so they gave a bolus of each and started her on a sodium bicarbonate infusion. 2 hours later, her ECG looked like this. It's atrial fibrillation with a ventricular rate of 90 and a QRS duration of 184 milliseconds. After another 2 hours, sinus rhythm had replaced the atrial fibrillation with a ventricular rate of 91 and a QRS duration of 136. It's interesting that the AF reversed it after treating the flecainide. It fits with the idea of extremely slow conduction worsening reentry because the wavelength is shortened. What if the patient was instead a 28-year-old who'd taken a deliberate overdose of, say, 40 100 milligram flecainide tablets? Again, you're going to want to call a toxicologist right away, but then call everybody else. It's treated like a severe tricyclic overdose. Give them sodium bicarbonate, intubate, hyperventilate them, give them more sodium bicarbonate. This might be one for gastric lavage as long as it doesn't distract from other management. Give them supportive care. Isopranoline reverses some of flecainide's effects in the EP lab, but you probably want something more like adrenaline as a more balanced inotrope that won't cause hypotension. Flecainide's a local anesthetic and some recommend lipid emulsion, but this is controversial. You should expect this patient to rapidly deteriorate to cardiac arrest. So if you're lucky enough to have access to VA ECMO, this might be life-saving. Again, if you ever see a really wide amorphous rhythm like this, do not give drugs, give them IV calcium and sodium bicarbonate. This patient had a potassium of 8. You can see some dissociated pacemaker spikes as well. Hyperkalemia and class 1 agents impair both pacemaker capture and potentially even sensing. Some of these aren't as obvious. If the patient here was 70 years old with a cardiomyopathy and shortness of breath, this might be VT, although it would be on the slower side at just over 130. If it was a 25-year-old who presented with coma and seizures, it's a tricyclic overdose. Okay, that's enough poisons and potassium. What are our other pitfalls? This rhythm shouldn't be too difficult. It's technically a broad complex tachycardia, but it's completely irregular with consistent QRS morphology, which is almost always going to be AF with aberrant conduction. This P is for physiological. The arrhythmia was not the major problem. This patient was admitted following out-of-hospital cardiac arrest with multi-organ failure. This one also has a right bundle branch block morphology, but look at the rhythm strip. There's obvious P waves. This is sinus tachycardia, physiological. This ECG came from a thoracic surgery patient with occult hemorrhagic shock. He needed to go back to theatre. This one's slightly trickier. Left bundle branch block pattern, about 150 to 160, and it's mostly regular. Remember, is it regular or irregular, narrow or wide, and then look for atrial activity, and there's something else going on here. What are these? That's not part of the QRS. You can see it better in the pauses. These are flutter waves. This patient had an acute coronary syndrome. The arrhythmia probably wasn't helping, but it wasn't the main issue. Next one, broad complex, regular, rates about 190. Surely this one's VT. It would be, except we haven't done the last pitfall, pre-excitation. This is antidromic AVRT. There's basically no way to distinguish this from VT unless the patient presented with, hello, I have Wolff-Parkinson-White syndrome and this seems to be my usual AVRT. If in doubt, it would be safest to just treat this as VT, probably with electrical cardioversion. If it was known AVRT, maybe you could try vagal maneuvers first. Why is pre-excitation a pitfall again? Because of this, unlike AF and bundle branch block we just saw, this QRS morphology is wildly fluctuating between broad and narrow complex with a spectrum of fusion beats in between. This is one of the situations where giving most anti-arrhythmic drugs could be lethal by favoring conduction down the accessory pathway. your drug options are going to be limited to canonical class 1A and 1C agents, such as flecainide or procainamide, or a pure class 3 agent like ibusilide. The safest first-line option is electrical cardioversion. This one's very fast, over 200, and not super broad. It's regular. I'm not going to touch the question of distinguishing SVT with aberrancy from VT based on ECG morphology. It's not safe. Out of interest, this one's VT. We know that for sure because there's dissociated P waves in V1. This does have a couple of features that might suggest SVT with a right bundle branch block. How do you tell them apart? Well, the real-world sensitivity for the Brugada algorithm is about 92%, which means if you applied it to 13 patients with VT, you would misdiagnose one of them as SVT. If you gave that one a calcium channel blocker because you're trying to be nice, they might die. There is a much safer algorithm. You've basically already seen it. Check it's not less than 120 or sinus rhythm, that's physiological covered. If it's not AF and you can't distinguish AVRT anyway, we can ignore pre-excitation. If it's relatively slow and super wide, rule out potassium and sodium channel blockers. But if it's not a pitfall and it all comes down to SVT with aberrancy or VT, then you can use this one last rule. It's always VT. Now this might seem simplistic, but the sensitivity of this rule for VT is 100%, which makes it better at avoiding false negatives than every other clinical prediction instrument. If a patient comes in with SVT, you'll be able to tell because they probably have a narrow complex. But if it's broad complex and you follow this one rule and cardiovert them, what happens? It works. Then you can get a nice baseline ECG for reference, maybe send them to a cardiologist. They might be able to get adenosine next time. Why exactly is VT such a problem? It's time for some quick hemodynamics. For simplicity, I will focus on the left ventricular pressure volume loop. We start in diastole with the end diastolic pressure volume relationship. A slope or function that gives us a pressure for a given volume is known as elastance, which is the inverse of compliance or capacitance. The LV end diastolic volume is determined by preload and how it interacts with the curve. Increased heart rate decreases filling time, while synchronized atrial contraction enhances filling. Any rhythm that causes dysynchrony between the atria and ventricles negates this effect. Since this dysynchrony prevents the atria from emptying efficiently, that retained volume reduces the compliance of the pericardial sac, which further impairs ventricular filling. You're probably aware that the state of the ventricle at the end of systole depends on a different pressure-volume relationship, but it's always the same ventricle, so these functions are on a continuum of time-varying elastance, and this gives us our pressure-volume loop. What's the most important dimension of this red shape? It's the stroke volume, because that determines our cardiac output, and it's important for blood to circulate. The line between end diastole and end systole depends on another function, and if we keep that constant, you can see a direct relationship with preload and stroke volume. The assumption that the function does stay constant is why people tend to use ejection fraction to describe systolic function, because it's thought to be less sensitive to changes in preload and than some measure of stroke volume or cardiac output. So what does determine this slope? You can think of it as proportional to the product of heart rate and systemic resistance, which is also known as afterload. A high afterload will increase the end systolic pressure, but decreases stroke volume. A low afterload increases the stroke volume at the cost of blood pressure. For the effect of heart rate, we should also remember that heart rate impairs filling, so an isolated tachycardia will reduce stroke volume without necessarily having a huge effect on pressure. It's hard to predict exactly how this will change cardiac output because it's the product of stroke volume and heart rate. Finally, stroke volume is also dependent on contractility. Remember, all positive inotropes are proarrhythmic, and most anti-arrhythmic drugs are negative inotropes to varying degrees. In the tachycardia algorithm, I mostly talked about wide complex tachycardias as presenting a diagnostic dilemma, but even a bundled branch block will impair contractility through desynchronous ventricular contraction. This is the basis of cardiac resynchronization therapy in heart failure. When we test ventricular pacing wires after heart surgery and they have a normal underlying rhythm, their blood pressure drops immediately with those ventricular beats despite the rate being a little faster because of the significant negative inotropic effect of ventricular desynchrony. I mean, obviously, if the underlying rhythm is asystole, it's better than nothing. There are a couple of reasons why ventricular tachycardia is especially detrimental to hemodynamics. Firstly, it's usually very fast. Secondly, it always involves both atrial desynchrony and ventricular desynchrony. Polymorphic VT is worse still, since the irregular rate leads to random preload and erratic calcium cycling impairs both contractility and relaxation. Finally, it's more likely to degenerate into VF. Ventricular fibrillation is the most extreme tachyarrhythmia. Because the electrical activity is chaos, there's no meaningful contraction or relaxation. This rhythm is incompatible with life since the stroke volume and cardiac output are zero without external mechanical support. If you're treating a patient for an acute arrhythmia, there's a decent chance they didn't have normal cardiac function at baseline. In chronic systolic cardiac failure, the heart has impaired contractility, but it's had time to dilate and augment its filling with volume overload, so it can still achieve an adequate stroke volume. Remember, their cardiac output is 1 stroke volume per heartbeat. Let's do a hypothetical case. A 68-year-old man presents to the emergency department after an episode of resolved palpitations with associated presyncope and no chest pain. He has a history of ischemic heart disease and dilated cardiomyopathy with an LV ejection fraction between 25 and 30%. You want to know, is he well, sick, or critical right now? And part of that question is, does he have an adequate cardiac output? You can see his vital signs on the monitor. On exam, he's alert and oriented, has warm peripheries, central cap refill time is 2 seconds. His chest is clear with no respiratory distress on room air. To put it another way, he's warm and dry. Is he well, sick, or critical? He's well. His VBG is normal, apart from a potassium on the low side, probably from diuretic therapy. Because this is hypothetical, we can also quantify his current hemodynamics. His ejection fraction is reduced, stroke volume and index are adequate. His cardiac index is low normal. We could have guessed all that from his vital signs and examination. Suddenly the monitor alarms because he's now in a regular broad complex tachycardia. We can see his pressure volume loop is radically different, but how's the patient doing? On exam, he's now restless and diaphoretic. His cap refill time is 6 seconds, with scattered crackles on auscultation, cold and wet. Blood pressure and sats are a little worse, but seem adequate. So right now, is he well, sick, or critical? The answer is critical. This patient is going to die within the next hour if you don't treat him. Blood gas just shows a bump in his lactate and some respiratory distress. If you waited an hour, you could note that he hasn't made any urine, but he doesn't have an hour. What are some numbers for his hemodynamics? Well, they're terrible. You can't see those numbers at the bedside, but it's very important to identify that despite a low normal blood pressure, he is in full-blown cardiogenic shock. Pulse pressure correlates with stroke volume to some extent, but the most important part of a hemodynamic exam is just to touch their skin and check a cap refill. Capillary refill time is probably the best surrogate measure of cardiac output. We can tell from the monitor this is a sustained monomorphic VT, probably scar or cardiomyopathy related. It's a reentrant tachycardia and the patient is very much unstable, so the only treatment option is electrical cardioversion. He's awake and has a pulse, so it should be a synchronized shock, ideally with some sedation or analgesia. I wouldn't be slogging him with propofol because of his hemodynamics, but for a malperfused brain you won't need much. A bit of fentanyl, a bit of midazolam, maybe some ketamine. I've occasionally cardioverted a patient without sedation because they were clearly in the process of arresting and we didn't have time. It's going to be the best chance to save their life, and it is less painful than fractured ribs from CPR. Ventricular tachycardias are probably the rhythms people are most scared about managing. First thing to say is it's a very heterogeneous group, which is why I thought it was worth breaking them down further. Like before, when we had regular and irregular, we can divide VT into monomorphic and polymorphic. The next most important conceptual division is their basic etiology, and we only have two groups, triggered activity and reentry. Automaticity causes accelerated idioventricular rhythm. Remember, it's not classified as VT because it's less than 120 beats a minute, and the management is to ignore it and it will get better. I'm going to start on the reentrant section because they're more common, and two of the most important ones are both in the setting of structural heart disease. The first is your classic reentrant monomorphic VT that's either due to an old ischemic scar or cardiomyopathy. First line treatment is electrical cardioversion, stable or unstable. If they're stable and you want to try medication instead, the two most common options are procainamide if you have it and amiodarone. The ProCameo study suggested that procainamide was safer and more effective in this setting. Unfortunately, many parts of the world, including mine, don't have access to it. From various guidelines, third-line agents include lidocaine and sotalol. The next important reentrant arrhythmia with structural heart disease is polymorphic VT in the setting of acute ischemia. A reentrant polymorphic ventricular tachycardia is inherently unstable and on a spectrum with VF. Therefore, the immediate treatment is electrical cardioversion. Since the patient is actively ischemic, the next priority is going to be revascularization. From a medication point of view, all of these patients should receive beta blocker therapy at some stage, and these are the first-line anti-arrhythmic drug. Part of their mode of action here is by reducing myocardial oxygen demand and ischemia. If you need a second-line agent, amiodarone is recommended. Amiodarone was originally released as an anti-anginal due to its vasodilating properties. If you need a third-line agent, it's probably going to be lidocaine, which is thought to be more effective in ischemic tissue. Now let's look at some triggered activity. We can further subdivide these into DADs and EADs. As I covered in Chapter 4, DADs can cause either monomorphic or polymorphic VT, while EADs only cause one polymorphic VT, which is torsades. Let's start with that one. You'll know it has that classic appearance. It's associated with a very long QT and perhaps some of those precursor signs from Chapter 3, and it often stops and starts. First line treatment is IV magnesium. There's different ways to dose it. Remember, 1 gram equals 4 millimoles, and the emergency dose is typically 4 to 8 or 5 to 10 millimoles, and if that's easier, over 5 to 10 minutes. Usually that's followed by an infusion of 1 gram or 4 millimoles per hour. If the rhythm is sustained and the patient is pulseless, it's probably transitioned to a reentry mechanism to treat it as VF and defibrillate them. The other first line management is to treat the cause if it's an acquired long QT. This means if it was a pause or a bradycardia, they might need their heart rate augmented. If it was hypokalemia, give them potassium. If it was medication, stop giving them that. If it's refractory to magnesium and you need a drug, lidocaine is probably the best option. It's one of the few anti-arrhythmics that shortens the action potential. For prophylaxis, the congenital patients should all be given beta blockers and potentially mexiletine if it's long QT3. There can also be a DAD associated polymorphic VT. A major cause is catecholaminergic polymorphic VT that can present with a spectrum from ectopics and non-sustained beats to bidirectional VT all the way to polymorphic, but the morphology looks nothing like torsades. This arrhythmia is tightly linked to sympathetic stimulation, so the first-line treatment is beta blockers and sedation, following some of the principles of VT storm that I will cover next. Other possible agents are flecainide, which is an antagonist at the ryanodine receptor, and verapamil. As with torsades, it can degenerate into VF, so shock them if they lose output. Digoxin and other cardioactive steroid toxicity can cause the same plus an even wider range of arrhythmias. First-line treatment is digoxin-specific antibody. Lidocaine is also potentially effective. Sedation and correcting hypokalemia are also important adjuncts. Next, there is DAD-mediated monomorphic VT, known as repetitive monomorphic VT or RV outflow tract VT, or sometimes as adenosine-sensitive VT. It's often non-sustained, usually benign, and can also be treated with beta blockers. For completeness, there's a rare malignant form that can cause polymorphic VT, but at probably less than 3% of these RV outflow tract cases. This DAD-mediated rhythm is one of the syndromes known as idiopathic VT, which causes VT without known structural heart disease. The other major one is vesicular VT, also known as idiopathic left ventricular VT or verapamil sensitive VT, as it's a reentrant circuit with a portion that can be interrupted by a calcium channel blockade. Personally, a patient would have to be holding a recent echo report and a letter from their cardiologist before I treated their VT with a calcium channel blocker. You can always shock them as well, that will work perfectly well. Finally, there's a reentrant polymorphic VT or VF syndrome without a distinctive ECG phenotype. Obviously, it's VF, so treatment is cardioversion and probably an ICD. But if they're having recurrent arrhythmias and you need a drug to suppress it, the answer is apparently quinidine. Related to this are J-wave syndromes, including Brugada syndrome and malignant early repolarization. These are also diseases that cause reentrant polymorphic VT or VF, so first-line treatment is defibrillation and possibly an ICD. As discussed in Chapter 6, isopronolone has also found to be useful in suppressing arrhythmic storms in Brugada syndrome, along with quinidine due to its transient outward inhibition. There's also short QT syndromes. These cause VF. Shock and quinidine. We've had idiopathic and channelopathies, but there's one more structural cause of reentrant polymorphic VT or VF. It tends to be seen in patients about 3 to 5 days following a myocardial infarction, but they're not in acute ischemia. It's thought to originate from short coupled ectopics in Purkinje fibers and has been known as His-Purkinje-associated polymorphic VT or angry Purkinje syndrome. It's unresponsive to most anti-arrhythmic drugs, including amiodarone. Can you guess what it does respond to? Quinidine. Remember this quinidine quadrangle. All causes of reentrant polymorphic VT apart from acute ischemia seem to respond best to it. It still has a use after all these years. But do not give it in torsades. About 40% of Purkinje-related polymorphic VT occurs with a long QT rather than due to a long QT, so it's been known as pseudotorsades. Just note that magnesium won't hurt for Purkinje-related, but quinidine is a really bad idea for torsades. If you're not sure, call a cardiologist. They should be able to distinguish it from the coupling interval. Finally, there's arrhythmogenic cardiomyopathy, which I guess could also count as structural. It usually causes a monomorphic VT, often precipitated by exercise, stress, and other sources of catecholamines. Treatment would be cardioversion if required. Beta blockers are protective, and apparently sotalol is next line, which is also a beta blocker. This might look like a lot of information, but it's not too much to remember. Cardioversion is first line for all reentrant arrhythmias and any pulseless VT or VF. For run-of-the-mill stable VT, you could try procainamide or amiodarone. For acute ischemia, it's revascularization and beta blockers. Torsades is magnesium and treat the cause. CPVT is sympatholysis. Digoxin, give the antidote. Adenosine sensitive is adenosine or beta blockers. Verapamil sensitive is verapamil or shock. ARVC is shock and beta blockers. Every other polymorphic VT should respond to shock and quinidine. What do you do if the patient keeps going into VT or VF despite shocks and maybe our first line drugs? Obviously, if it's something exotic like Torsades or Brugada syndrome, that will have its own specific management, which I've briefly outlined here. The final section of this chapter will focus on refractory VT or VF due to the most common structural causes, cardiomyopathy, scars, and acute ischemia. I know it's a bit dramatic, but I think electrical storm is an apt title. The condition is dramatic and it does share some features with a storm. A storm cloud is basically an engine that runs on warm, moist air that rises and condenses, releasing more heat. Our electrical storm starts with ventricular tachycardia. It could be due to electrolyte disturbance or ischemia. They might be generally unwell with sepsis or decompensated heart failure, leading to sympathetic stimulation, or it may just be a progression of their cardiomyopathy with further dilation and remodeling. The tachycardia causes a rise in intracellular sodium and calcium, and their associated signaling in a proarrhythmic positive feedback cycle. The heart rate worsens myocardial oxygen demand, worsening ischemia and leading to more sympathetic stimulation. The patient is in cardiogenic shock, which further worsens ischemia and leads to both endogenous and often exogenous sympathetic stimulation. They are also being electrically cardioverted repeatedly, either by us or their implanted device. Obviously, this causes pain and anxiety and further sympathetic stimulation. All of these positive feedback cycles make the causative arrhythmia hard to break. So how do we calm this storm? This can be broken into three simultaneous strategies: hemodynamic support, sympathetic blockade, and anti-arrhythmia therapy. Starting with the basics. If they need CPR, they need CPR. In that case, they also need cardioversion. If they have an ICD, you need someone interrogating it and potentially reprogramming it based on the situation. The first step for sympathetic blockade is sedation and analgesia. Think of it kind of like status epilepticus. If you can safely intubate them, it's going to help melt away a lot of that sympathetic drive. Our first antiarrhythmic drug is good old amiodarone. They should be on an IV infusion. At the same time, they should be given beta blockers, ideally regular propranolol. If you're worried about their cardiac output, you could use an ultra-short-acting infusion, but those don't have beta-2 coverage. While we're talking drugs, they probably also need some hemodynamic support. The focus should be vasopressors, not inotropes, because all positive inotropes are proarrhythmic. You certainly don't want to be bolusing large doses of adrenaline if you can help it. Use echo and continuous blood pressure monitoring to titrate therapy. You also need to treat their ischemia if that's what caused this. Revascularize them. Maybe they need a balloon pump. If you're not winning, some patients might be candidates for full mechanical circulatory support until the arrhythmias resolve. This wouldn't be a patient with end-stage cardiomyopathy unless they were planned for transplant. The final strategy for sympathetic blockade is cardiac denervation. The easiest form is either left or bilateral stellate ganglion block. An alternative is thoracic epidural anesthesia. This might be slightly more effective, but has more side effects and is potentially more physically challenging during a medical emergency. The last option for antiarrhythmia therapy is catheter ablation. You certainly want an electrophysiologist to be involved early. If you're curious as to what the stellate ganglia are, they are bilateral paravertebral sympathetic ganglia formed by merging the inferior cervical and first thoracic ganglia. The heart receives sympathetic stimulation most importantly via the stellate ganglia, but also down to around T4 or T5. Some patients, for example with congenital long QT syndrome, will undergo a permanent surgical stellate ganglion ablation as a variant of this, but a block can be as simple as injecting a bolus of 1% lidocaine under ultrasound guidance, which can be done in the emergency department. Chapter 10, that was the end of the content for this monster video. I do have some resource suggestions if you want more information. The European Society of Cardiology comes to the rescue again. If you want a single, up-to-date, evidence-based summary of anti-arrhythmic drugs and how to use them, it's this. This was suggested by one of my cardiologist colleagues. It's available for free online. It's like a mini textbook. Check it out. I'm always going to link to Range Physiology. It's the best starting point for any ICU basic science topic. For anything ECG related, check out Life in the Fast Lane. It's another Australian FOMED resource. It's this time for emergency medicine and happens to have one of the best ECG libraries available. Half of the ECGs featured in this video are from Life in the Fast Lane. ECG book is another more concise reference, so check that website out as well. For more clinical critical care topics, have a look at the Internet Book of Critical Care. It has great management algorithms for conditions such as VT and electrical storm. There are many good lectures on arrhythmia management for free on YouTube. I will first recommend anything by Amal Mattu. The man is a legendary emergency medicine educator, especially on cardiology topics. I'd particularly recommend listening to his appearance on EM Cases podcast with electrophysiologist Paul Dorian to discuss tachyarrhythmias. My tachyarrhythmia management slide and pitfalls are heavily based on his teaching. Megan Fix is also at the Centre for Medical Education and has another great lecture on wide complex tachycardias. Finally, William Brady at the Life Support Learning Centre has a multi-part series on wide complex tachycardias and his own algorithm. His chart from the University of Virginia ED was one of my data points for the 70 to 75% of wide complex rhythm statistic in Chapter 9. Regarding wider topics, Elliot Nicholson is a very prolific medical science YouTuber. I used his tutorials to get my head around certain topics like calcium signaling. Fox Terrier are a pair of clinicians who make very clear pathophysiology videos. Professor G is a brilliant pharmacology lecturer. My Class 1 state-dependent block section was inspired by her video on the topic. Joshua Cooper is a cardiac electrophysiologist. His videos are incredibly informative and I needed them for the section on scar-related VT. Finally, Pradeep Rangappa is an intensivist who makes videos on a broad range of ICU topics. My most comprehensive reference sources were up to date for clinical topics, Bronwald's heart disease and this cardiac electrophysiology book. Both also have their companion books. If you want something a bit more introductory for electrophysiology, I recommend one of these. I went through a bunch of other books on arrhythmias, many published by Singer, hence the colour scheme, as well as some more general physiology, pharmacology and toxicology. These are probably the most important examples. I also used a couple of physiology simulations making this. I'd like to thank Dr. Puglisi for sending me a copy of LabHeart. It was very educational and the fast action potential waveforms in this video were based on one of the outputs from the software. I also used Harvey, which is an iPad pressure volume loop based hemodynamics stimulator for the VT case in Chapter 9. I made 2 excitable myocyte simulations in GameMaker Studio and processed them in Photoshop for the animations. Apart from the few third-party videos, the rest of the animation on this was done in PowerPoint. I also read and referenced hundreds of journal articles making this. I'll try to link to the most relevant ones in the description. If you want to know where a certain fact or concept came from and it's not clear, please post in the comments and I'll probably be able to tell you. Thank you so much for watching, especially if you watched all of this. I put an almost absurd amount of work into this video, so I hope you found it useful. If you did, please subscribe, comment, and share with others. I might upload some sections as their own videos, like I did with the unfinished nutrition video. I think I can comfortably promise that the next topic will be shorter and take less time to produce than this one. Bye for now.